morning, both to those people online, virtually, as well as to the people in the council chamber. So it is 10 o'clock. Good morning. Welcome to the first meeting of this committee of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your chair, County Councillor Jeremy Pert. So before we start this morning's meeting, I would like to say a few words by way of introduction. Firstly, about today and the operation of this committee. It is approximately 15 months since there was any committee or council meetings at county buildings, and so I'd like to welcome members and new members back to county buildings. I must say a lot has happened in that time, not least the loss of 128,000 lives prematurely in the UK. And putting that in context, last year in 2020, there were 608,000 lives, which gives you that context, which were lost overall. I'm sure we all know people in our communities, family, friends, who have died as a result of the pandemic. So I'd like to lay on record this morning our thanks to everyone involved in supporting the efforts during the past 15 months, whether that be in the NHS or in social care or in the voluntary sector, and to make sure that we continue to abide by the government's guidance in terms of hands, face, space and open space to ensure that those losses of the last 15 months aren't in vain. This is a new committee, so about 50%, just under, of the committee are new. So I think it is only appropriate that this morning we look at the role, remit and scope of the committee, and equally decide jointly the work programme. I also welcome Councillors Edgeler and Northcote to their roles in scrutiny and overview. Today's meeting is live for the committee, that's face-to-face obviously, but remotely for visitors, as this room cannot facilitate social distancing for us all to be face-to-face. So if I can make a few suggestions, if you want to speak, if you want to wave at me, then I will note that and add you to the list and call you appropriately, or try and call you appropriately, as and when it is your turn. For those remotely, please can I ask that you raise your hands virtually by way of the raise hands button, and we will try and see that and take you in order. It's not as easy as if this was a fully remote meeting, so please do bear with us and please, if need be, do feel free to interject briefly just so that we don't miss your interventions. For those of us even in the chamber, the way to speak is to press the microphone button on the left-hand side, and that then puts a red light on, and equally when you finish speaking, if you can turn off the microphone, that would be very helpful. That ensures that the conversation is recorded, seen by the members of the general public, and equally anyone on a hearing loop can hear and follow what is going on. For those of us on Teams, please can I ask that we keep our microphones off, cameras off unless speaking, and that ensures that we maximise the use of the bandwidth and everyone can follow what's going on during this morning's meeting. Just a note in terms of going forwards, I would like to see some element of hybrid meetings continuing for two reasons. One is it ensures the best attendance of the best quality individuals to come and be scrutinised by this group. I don't think it's fair to ask a chief exec of an NHS trust to travel for 60 or 90 minutes to come and talk to us for 10 minutes. It's not an appropriate use of their time, so I think that's one of the reasons I'd like to maintain some level of hybrid. And secondly, if we're going to build back better, we need to hardwire some of the benefits of technology that we've seen over the last 15 months. So just turning to the second element I wanted to talk about, which is the sterling work that's been undertaken by all in social care and medical services throughout Staffordshire. And without that work, we wouldn't be able to increase our freedoms. And the vaccination programme, both nationally and locally, has been an enormous success as part of that. And I think last week we passed the 1.2 million doses of vaccine delivered in Staffordshire and Stoke-on-Trent, and during this week we'll be extending jabs to those over 30. However, it is vital for our economy in Staffordshire that we continue to follow the government's guidance, and I would encourage members to first of all sign in to locations. So there was a scanning barcode within the county buildings this morning. I would encourage members to scan in, and that does help things like test and trace. And second of all, if you are like me, I have a negative, otherwise I wouldn't be here, lateral flow test, and I would encourage members to not only do that, but encourage those in your community to get hold of the free packs from pharmacies, libraries, and from the NHS direct to ensure that we can keep a track on this virus and on the pandemic, and ensure that we learn to live with it appropriately. So, before we move to the agenda itself, there are a number of things that we'll want to talk about and think about, and I just want to sort of put them out in your minds to start with, so you can start thinking about them before we go on to the detail. As part of the Building Back Better, we'll want to consider, I'm sure, things like GP access, things like the deficit of 157 million within the local NHS system. I'm sure we'll want to assess the fragility or otherwise of the social care markets locally. I'm sure we'll want to look at the benefits that came through the working together during the pandemic to make sure that we can use those benefits of partnership working to build back better, and we don't revert to where we've been before. So before we start the agenda of the day, it would make sense, given most people haven't been all together in the same room before, for us to start introductions. So could I ask that we start from my left-hand side, that's Charlotte, you first, and then just go around and just say who you are and who you're representing or what your intentions are. We'll do it in the chamber first, and then we'll pick up those people online. Thank you. Charlotte.
Okay, well, I'm Charlotte Atkins. I've been on this committee for some time. I represent League South, and I'm leader of the opposition.
Good morning. My name's Keith Lunder. I represent Biddulph South and Endon, and I'm new to this committee, but been on many other committees throughout the last 4 years. So I'm back for another session. Thanks.
Good morning, everybody. My name's Jill Hood, and I'm the County Councillor for Stone Urban, and this is my second, hopefully, batch of 4 years on this committee. Thank you.
Thanks, Jill. Should we go to David?
Yeah, I'm David Latham, Lichfield District Council, representing that District Council on this committee. I've been with this committee for, I don't know, 8 years, I think, so I'm getting used to it now.
I'm Barbara Hughes. I chair Health Scrutiny at Staffordshire Moorlands District Council, and I've been on here for about 8 years.
Well, good morning, I'm Jack Abrahams. I'm the County Councillor for Person, and this is my first committee.
Good morning, everybody. I'm Joyce Bolton, representing South Staff's District Council on this committee. Thank you.
Hello, I'm Councillor Martin Buttery. I'm here to represent Cannock Chase District Council on their Health and Wellbeing Scrutiny Committee.
Good morning, my name is Phil Hewitt. I'm County Councillor for Hensford and Rawnsley.
Good morning, my name is Paul Northcott. I'm the County Councillor for Newcastle Rural, representing Newcastle under Lyme District Council. I've been on this committee for some while now. Thank you.
Good morning, I'm Janice Sylvester Hall, and the newly elected member for Lichfield City North, and this is the first time on this committee.
I'm Philip Atkins. I haven't been doing scrutiny for 12 years because I was leader of the County Council. I'm the member for Uttoxeter Rural. I chaired the Health Commission, which set up health scrutiny in Staffordshire, which involved all the districts and the county. And my advice, Chairman, is whatever anybody takes you off in, always hang your rope anchored to a rock, that this is about health, not the NHS. and I'm looking forward to scrutinising and overviewing in the future.
Good morning, everyone. I'm Councillor Anne Edgeler, and I'm the county councillor for Stafford South East Division and Vice Chair of Scrutiny on this committee. And I've been on this committee, I can't remember when, because I was on it from district before I became a county councillor. I think I'm the only person in this room that's probably was interviewed by the Francis Inquiry, but that's how long I've been associated with health. Thank you.
Good morning. Richard Cox, County Councillor, newly elected for Lichfield Rural West. I have been and still am a Lichfield District Councillor, and I look forward to working on this committee.
Just to pick up the officers within the room, Nick.
For those of you that haven't met me before, my name's Nick Pountney. I am the Council's Scrutiny and Support Manager, so I have overall responsibility for the strategic direction of scrutiny. I'm supporting this committee in going forward to make sure that everything is exactly as we want as a council.
Good morning, I'm Deb Breeden. I am the Scrutiny and Support Officer for the Health and Care Overview and Scrutiny Committee.
So we'll try and pick up online now. So let's start with Tracy. Do you want to start and then on to Marcus and Tanisha, then Lynn and Paddy, and then Simon?
Good morning, I'm Tracy Shewan. I'm the Director of Communications and Corporate Services for the 6 Staffordshire and Stoke-on-Trent CCGs and the Integrated Care System.
Morning all, I'm Marcus Walnes. I'm the Accountable Officer for the 6 Staffordshire and Stoke-on-Trent CCGs.
Morning, I'm Tanisha Steele. I'm the Digital Communications Assistant in the comms team. I'm here for comms support for Tracy.
Morning everyone. I'm Lynn Miller. I'm the Director of Primary Care and Medicines Optimisation for Staffordshire and Stoke-on-Trent, and I'm here in my capacity as Programme Director for the Vaccination Programme.
Hi, I'm Dr. Paddy Hannigan. I'm a GP in Stafford and Chair Stafford and Surrounds CCG, but I'm here today as the clinical lead for the vaccination programme.
Hi, good morning everybody. I'm Simon Whitehouse. I'm the ICS Director for Staffordshire and Stoke-on-Trent.
Thank you. Good morning everyone online and everyone here. Welcome. Good news was that our cameras worked, so if I can encourage people to sit in the middle of your seats, then the cameras did work, so don't anyone move. But if you do like me and wander down the benches, then the camera doesn't pick you up. So that's worked very well. Thank you. And Philip, as ever, makes some really good points touching on Francis, and I'm sure we will do so shortly. And second of all, we're not talking about architecture. What we're talking about is the health of our residents, and we must not focus in on buildings or the architecture of how the NHS works, otherwise we'll fail completely. So let's turn to the work this morning. It seems like that's been a long start. We won't do that every time, but thank you for bearing with me. So apologies, Debs.
Yes, Chair, we've got apologies from Councillors Jessel, McMahon, Ian Wilkes and Rosie Claymore.
Thank you. I know it's not on the agenda, but I can confirm that we're quorate, and I see no reason why that won't remain the case. 2, declarations of interest.
I'm the partner governor from the County Council on MPTN.
Thank you. Anne, is there anyone else? No one indicating, so we will continue on to 3. So, minutes of the last meeting, can I ask that the minutes are approved as a true record for those people who were there? That's not everyone in this room. Okay, I think I've seen nods and acceptances for all those people there. Yes, I've seen nods and acceptances for everyone there. The only thing I would say in terms of the minutes that I would just like amending is on page 2, line 2, paragraph 2, the insertion of the word Staffordshire. Doesn't change the meaning of the paragraph. It just means that it reads that in response to a question, the clinical lead confirmed that supplies of vaccines in Staffordshire were currently sufficient to meet needs. Okay, we're happy with that? Brilliant, thank you.
Chair, if the committee agree that, we will note that in the minutes.
Thank you, Nick, that's helpful. Are there any matters arising not on the agenda that people want to pick up? No, okay, that brings me on to item 4. And there is a presentation for item 4. I'm hoping that's going to come up. Ah, okay, that's brilliant, thank you. Can everyone see that, both online and... That's fine. There's a story there. So just in terms of introducing this, I wanted to make sure members had some context for the work that we are doing. There's obviously some members who've been part of the creation of the architecture, involved with the running of the committee, but also I'm mindful there are some new members to this committee, and I think it's a good refresh from time to time, just to make sure that we do look at what the role and scope is of this committee. So I've asked Nick to talk about that, and I think it's really relevant because following the mid-staff scandal and the excess deaths that happened between 2005-2008, it brought about some fundamental changes into how health scrutiny was undertaken. And I think it's really important we're clear from a local district point of view, and you all have district roles or district influence, as well as from a county perspective. So let me hand over to Nick.
Thank you, Chair. If I stand, members, can you still hear me through the microphone? And looking, am I still on camera is the question. It'll get there. So the reason why we do this, health and care scrutiny, overview scrutiny, is very, very different to the other 3 committees that we have in the council. And those members that have been involved in this committee will be aware of that. So it's a good refresh, as the chair says. It's also a really good reminder for the new members that are joining this committee as to what their role and purpose is. So, the health environment, I think the chair has actually really well covered that as to where we are at the moment. The relationships and roles, so we have online some of our external partners, the CCG, Health Watch, who are part of the work that we do. CCG and boundaries, we've already covered that, and later on you'll see in a slide exactly what the area of Staffordshire covers. Health scrutiny regulations. The health scrutiny members of this committee have powers that are not available to other overview and scrutiny committees. And so I need to outline to you what those are. And that covers bullet point next. And then your statutory duties. So as an upper tier authority, we have a statutory duty to scrutinise both our own internal services, i.e. what we provide with adult social care, and I know that Dr. Richard Harling is going to speak to you later about his challenges and his areas, but also we have to be concerned with what our NHS partners are delivering. The arrangements in Staffordshire, I've already heard a number of members speak this morning. We have a joint working arrangement in Staffordshire whereby both our council and the district and borough councils, all 8 of them, have a joint working relationship, and I'll go into more detail on that as we go forward. Actually, the role, and you'll have a presentation later about your role and what you want to scrutinise, and actually what's within your remit going forward. I think someone's moved the slide forward a bit too fast there. Sorry. And then training and development. So actually, what you as members feel we can provide for you to enable you to carry out your role as best of your ability. Thank you, Deb. So, health scrutiny came in 2002. So the original health scrutiny legislation was laid down in 2001. That was where the cabinet structure, the cabinet model was laid out, and decision making was put in control of a cabinet stroke executive model. Health scrutiny followed very shortly behind, and the health scrutiny role there by the Department of Health was laid out in 2002. So health scrutiny has a distinct role within the scrutiny and cabinet model going forward. So these are the bodies that you will deal with. So as a member of the Health and Care Overview Scrutiny Committee, you will have very close links to. If I start off on the left, the clinical commissioning groups. You have online both Marcus Warnes and Tracy Schwan, who are leads for our contacts with the clinical commissioning groups. They are the commissioners of services, so they decide and they pay for where our services are provided for. We also have very close links with the Health and Wellbeing Board, so that is administered by the Council, and we are the body, you are the body, that scrutinises their outcomes and what they are delivering as a distinct board. We also have relationships with other bodies. The most important one is probably Health Watch. So Health Watch have an observer seat on this committee. They're non-voting, but they are asked to input and give us advice and guidance on work that they are doing that may influence your work going forward. And NHS Trusts right at the bottom. So the CCG commission services, but when they consult with you, and we'll come on to this later about you being a statutory consultee on the change or amendment to service delivery, the providers, so we're talking about the chief execs of Royal Stoke, New Cross Hospital, Burton and Derby hospitals, they are very closely aligned with this committee's work. So, this is the 2012 Act. So this amended how health scrutiny operates. It's a very simple diagram. So Health and Wellbeing Board, they are the lead strategic body for health. They encompass a number of people in the sense of bodies such as the county council, district councils, the health bodies, co-chaired by one of your colleagues, Councillor Johnny McMahon, who is the support member for public health, and they actually lead on the strategic direction of the authority and its partners in how health is delivered. Important thing there, one of our roles, your roles, is to scrutinise their outcomes and the delivery of what they are looking at in their joint strategic needs assessment. We then have Health Watch. Health Watch are an independent body commissioned by the council, paid for by the council. They have a contract with the council, and they are an independent view on health services within the local area. You will be asked at time on your work programme to scrutinise what they are delivering against what we are contracted them for, and to demonstrate their delivery of services and their delivery of intelligence for you to enable, and the council to enable the correct process going forward. And then yourselves, health scrutiny. You know, you have powers that no other overview and scrutiny committee has. You have the power of referral to the Secretary of State. I'll come on to that later. You have the power to bring external partners in, to be questioned, to be challenged on the services that they provide. That is not available to any other overview and scrutiny committee. And the middle point is most important. This committee is there to exist. I'm sure the chair will support me in delivering better outcomes for the people of Staffordshire. So, clinical commissioning groups, and I'm sure either Marcus Warnes and Tracy Schwan will expand on this going forward, but this is the current position. So, we have all general practices authorised and licensed are part of the CCGs. We have at the present 6, which cover every area of the county. They commission acute, local and tertiary services as required for their populations. And I think the important thing there is, going forward, and I've been a lead on health scrutiny for a very long time, it's about different populations have different needs. So focusing on what may be right for Moorlands may not be right for Tamworth or may not be right for South Staffs. So making sure that that local need is addressed and actually taken into account when looking at commissioning of services. And they have a duty to cooperate and work with us as a county council, as local authority care commissioners. So these are the current boundaries. So we have 8 districts. We have 6 clinical commission groups. That doesn't make it nice and tidy, as I'm quite sure you can see. And actually, the most difficult one is the land bridge between Seaston Peninsula and the far right around East Staffs. However, that's been in place for a while, and I will let our colleagues from the CCG expand on that further when they talk to us later in the presentation. So, regulations. 2012, that gave you, as a committee, a large amount of power, stroke influence over how health is delivered in Staffordshire. They are the centre, patients public, they're the centre of health services. So, when you're looking at what's on your agenda, and I know you're going to have a lengthy presentation from both the Chair and Deb and the CCGs and Dr. Richard Harling about how you should format your work programme, but that top bullet point is the key point. Your role about being democratically elected members and voicing your health concerns, I think the Chair will support me in this, is we really want to hear what you're hearing from your constituents. However, we don't want to be focused on individual demographic areas. We want to actually hear what's happening in Staffordshire rather than what's happening parochially in your area. You have powers. They're given to local authorities and social services responsibilities. So actually, one area that I think, if I'm being really blunt, that I think we've not been really good at is we've been scrutinising the NHS. We are in the middle of a pandemic. We have focused very heavily on what our external provider is doing. But actually, I'm sure Dr. Harling will expand on this, we've not really focused on what we do as a local authority with regards to adult social care, and that may be something out of your work programme planning that you might want to consider going forward. And then issues of wider concern to local people. So I'm sure you have knocked on the doors during your campaigning, your election period. I'm sure you've been given advice and guidance from your constituents. We want to hear that. So if there are local concerns, if there are issues that have been raised during your election campaign, that is really important. And then health inequalities. So certain areas of the county we can pinpoint as having particular areas of health inequality. It may be pregnancy, it may be IVF, it may be obesity, but different areas of the county have different issues. So we want to hear about those and maybe focus on the areas that may come on board. So, you are an official consultee. That cannot be, I almost want to put that in bold and underlined. If the NHS or the County Council want to change service delivery in Staffordshire, they are obliged by statute to consult with this committee. It's not optional. They have to come to this committee and say, we are thinking of doing X or Y, and we would like your views on that change. That is probably the biggest role this committee has. They can require an officer of the NHS to attend a meeting. So if you say, as part of your work programme, we want to look into item X, issue Y, we can, as an officer team, via the chair, require an officer to attend this committee and to be held to account on the issue that you feel is important. You can make reports and recommendations. You can't tell the NHS what to do. You can't give them decisions. However, you can make very strong recommendations to the NHS about your feelings and about how you feel NHS services are being provided. I will put another add to that. You can also do that with our own internal services, so you can make recommendations to the appropriate cabinet member and the SLT lead for adult social care, who's Dr. Harling, and you can make recommendations to them as to how we're delivering adult social care. You can co-opt members to the committee. So we've already co-opted 8 district councillors. So we took a decision about 10 years ago that joint working was the way forward. We have 8 district and borough members that sit on the committee. You could also decide to co-opt other members that you feel appropriate to the committee as and when you feel. You can delegate powers to other authorities. We've done that. So previously, we have had set up a joint working arrangement with our 8 district and boroughs, and we have a joint code of working agreed by all 8 leaders, plus our current leader, as to how we will operate under a delegated authority, in the sense that the council, as an upper tier authority, has health powers, and we've chosen to delegate some of those powers to our 8 district and borough partners. We can set up joint committees. Doesn't happen very often, but if the CCG, if the NHS, if our adult social care leads decide that they would rather discuss the issue, debate the issue as a joint committee, we could be in the situation whereby we set up a joint committee. That would almost certainly be with Stoke-on-Trent in the past. Referral to the Secretary of State. Doesn't happen very often. We've had a couple. So if, as a committee, you are really outspoken and you are really in the majority opposed to a change in service delivery, to a change in what the NHS or our adult social care providers are delivering, then you can make a formal referral to the Secretary of State for Health. No other committee has that power. But that would need to be by a majority vote of the committee and would need to be a formal referral from the chair of the committee on behalf of the committee to make that referral to Secretary of State. The Secretary of State is then obliged to make a response to that referral. And the last thing, the one power you don't have is you can't visit. So if you ever come into contact with Health Watch, or you ever come into contact with our other consultatory bodies who have a right to visit ad hoc, we don't have that at Staffordshire Health and Care over the Scrutiny Committee. So you don't have a power to visit. That's not to say that our partners don't welcome visits, but it would have to be planned, organised and actually coordinated. We can't just turn up ad hoc. So I think some of this is already covered, but I'll go through it again. So they have to provide information to this committee. So if you as members, and I'm going to say the term that I'm sure you've heard in my training sessions, this is member-led scrutiny. So if you actually require information, if you require details on a particular issue, they are required to provide that. They need to make arrangements to officers to come before committee. So if as part of your work programme planning, you decide that issue X is important, then between our team, we will make sure that the appropriate officers are available to answer those questions and give you further detail. I've already covered this. You are a consultee, so any substantial service variation and developments need to come to this committee. The mode of operation that we've operated in the past is there is no detail as to what you class as substantial. So what we've tended to do is say to the NHS, actually, it's not for you to decide what's substantial, it's for us to decide. So you may get an email from Deb or myself that says, this is programmed as a committee, members, do you consider this to be substantial? If you consider it to be substantial, we'll put it on an agenda. If you don't consider it to be substantial, then we will give agreement that we acknowledge the change and we will let it go ahead. But it is member-led scrutiny, and it's for you to decide, not for the NHS to decide what is a substantial variation. Any reports or recommendations that you may make against anything that they bring to your committee, they are required to report back within 28 days, and obviously we will circulate that response to you, and then you can decide whether that warrants further investigation. And then consult to involve patients and public in the planning and provision. That's where our relationship with Health Watch is really important. So Health Watch are a contracted service of the County Council. They have heavy involvement on the consultation front, and certainly I know colleagues in Health Watch are keen to give you the information that you need going forward, so it might affect or certainly look at your work programme in what you should be debating. So, hopefully you all already know this. So, largest committee, largest overview and scrutiny committee on the council, 21 councillors, 13 of which are appointed by the council, and then 8 who are appointed by their district and boroughs as full voting representatives on the committee. Those 8 councillors have exactly the same responsibilities and the same rights as the county councillors that are appointed by ourselves. So it's a committee of 21, no difference. We don't in any way take a different opinion as to whether they've been appointed by the council or appointed by the district boroughs. Health matters, local concerns. So there is a continual conversation, and this will continue going forward. So where we look at an issue that we think is county-wide, then the County Council's Health and Care Overview Committee will pick that up. Where you may have a local health inequality, particularly around, let's say, a GP service, then we would ask the County Council to refer that to the district and borough for their consideration. That does not need to be a formal referral. It just needs to be, actually, we think the local area should pick that up because it affects people, constituents in their area. And then we've got a joint code. Now, we are literally 3 or 4 weeks into this administration. We are about to review that joint code. So during the summer period, working with colleagues in our district and boroughs, we will be revising that joint code to bring it up to date, sending it out to the leaders of the appropriate councils for them to sign up to, and then circulating it to yourselves. So, additional responsibility. I've already mentioned, and I'll repeat it again, I don't think, because of the pandemic, because of the areas that we're working in, that we've been particularly good at scrutinising ourselves. So we focused on the pandemic, we focused on the NHS, we focused on the services that they provide. A comment I would really like to make is that when you look at your work programme, there are a lot of things that haven't been done because of the pandemic. So they've been held back. So services that may have been reviewed, services that may have been changed, both by the council and by the NHS, have been put onto the back burner, those are going to come forward to your committee very, very soon. And I think you need to be aware of that. And I'm sure colleagues in the NHS, when they speak, and also Dr. Harling, will touch upon those that have been put on the back burner because of the pandemic. Responding independently. You are a health committee. You are a group of members. You are independent. I think that's really important. So when you respond to a consultation, I just want you to bear that in mind, that you are responding on behalf of the leader of the council. You have been appointed to a health committee, which is within his power, and you are an independent body responding. You do not have the council's voice. You are a health committee that is independent of the council. Joint work with local communities. We have a lot of cross-border movement. So for those councillors that live in those areas where a lot of their constituents may actually access services outside our boundaries, so South Staffs into New Cross, Tamworth into Good Hope, you know, I could write a list. So we need to work with those committees to ensure two things. One, we don't duplicate, and two, that we don't let anything fall through the gaps. Because our constituents are accessing those services. And that covers the regional health scrutiny. I'm not going to talk too much about work programme planning because you've got an item on the agenda that's quite detailed about that. Role of vice chair, vice chairs and members. So, we are working with this. I'm working with my colleagues in the team. So we have a new process this year and the next 4 years, whereby we have a chair and we have two vice chairs, one who has the lead for overview and one who has the lead for scrutiny. So with regard to the chair, that role actually stays the same. So it's expected that the chair will, as far as the calendared meetings are concerned, chair the meeting. As far as work programme planning is concerned, will lead. And as far as working with colleagues in both the NHS and our own internal services, take the lead. However, with regard to the two vice chairs, where items are agreed on your work programme, that it is decided may be overview, and in the sense of overview, I mean forward planning, policy development, looking at areas where we can improve the council, then that vice chair will take the lead on that piece of work. With regard to the vice chair for scrutiny, it may be looking backwards in the sense of what areas of concern do we have about poor performance, areas where we can improve, and areas where we might look at our performance and think that could be changed. And then we have a health scrutiny officers group. So we will meet with the colleagues in our district and borough councils, and we will discuss how we do health scrutiny within Staffordshire, A, to avoid duplication, A, to give a clear direction, and B, just to make sure that we're all on the same page. So, you can ask questions of NHS bodies, and I really implore you to do that. I really want you as a committee to ask those questions. Challenge the cabinet member. So, you have a new cabinet member for health and care, Councillor Julia Jessel. You have a support member in Councillor Johnny McMahon, and I implore you to challenge them in the direction of travel that they are taking going forward. And also, what you're hearing on the ground, be it via your constituents saying about their GP services, be it via friends, family, anything that may come to light, feed it into the committee, and then the committee make a decision about whether that's a local issue or actually a county-wide issue. Challenging progress, performance. I know the chair is really keen about performance dashboards, both internally and externally. So he wants to see, actually, where are we? Let's start with the NHS. Where are we on cancer referrals, for example? Where are we on elective surgery? And then also internally, where are we with discharge to assess? So the Chair is very keen that we receive those performance dashboards, and that may form an opinion with yourselves as to what you should be looking at. Consultation. You will have items requested by both the NHS and internally, but more so the NHS, whereby they are out to consult, and as a statutory consultee, they want your views. My opinion in the past has been it's much better if it comes to you as a committee towards the end of the consultation, so you can actually listen to what they've been told, so you can actually respond with the hindsight of what the public have said. But as I said before, you are a statutory consultee, and they are required to bring something to you as a report to say they've consulted with you. And I hate to say the phrase tick the box, but it's not tick the box. You actually, they have to reference your opinions and your views in their consultation. In-depth reviews. So, as a committee, member-led scrutiny, if you've got a really burning issue, if you've got something that you want the committee to pick up, if you've got an issue that you want to do a bit more detail than you could possibly do in a calendared meeting where you might only get an hour, then you have the facility, particularly with your two vice chairs now, to say, can we go and form a working group, and can we go away and look at that issue and then report back to the committee our findings. That, I think, is really important. It's something we've probably, as a scrutiny function, slipped on. I think it's something that we need to really, really engage with. And I think if you've got a really big issue that you can't solve or recommend in one committee meeting, go away. We will give you the support from our team. The two vice chairs, I know, are engaged with that. Go away, look at it, spend a few meetings, get the right people to talk to, and then report back to the parent committee with your findings. And training and development, being involved. The one thing that keeps coming up, particularly with new members, is questioning skills. How do you ask the right question? How do you... We are there to support you in that. And we will certainly, for any member that feels they need further training or development, or even background knowledge as to how these committees work, that's what myself and our team are there for. And the last one, I think I've said this in the scrutiny and overview training. Be realistic. Be deliverable. So there is no point in spending a lot of member and officer time on something that actually maybe can't be changed. Certainly make recommendations, but what we want to really say is at the end of the first year that we've actually delivered recommendations that have actually made a difference to how either the council or in this case the NHS have delivered their services. Individual induction. If any member wants to sit with me or with Deb or with the chair and sort of get your head around how health scrutiny works, we are very aware it's complicated. It's very different to the other overview and scrutiny committees. We are happy to spend the time to bring you up to speed. And if any returning member just want to refresh again, the options open there. And I've certainly covered questioning skills, getting the right questions and getting the right answers. So it's so important. There's me and there's Deb. Deb is the lead officer for health scrutiny now, so I am the scrutiny support manager, but on a day-to-day basis, any queries you have regarding health, direct to Deb. If Deb can't assist you, then I am always available.
Thank you, Nick. Shall I just throw the floor open to any questions that have come into people's minds from what Nick has had to say? David.
Just a very brief one. Trying to contact your officers on the phone, you get an answer or a recorded message saying you've dialed an incorrect number when I haven't. Is that because you're not transferring them to home phones?
Maybe. I have a works email which I will circulate to the committee. I have no problem with that. Best thing to do is to actually email us. We all pick up our emails instantly, and we will then reply, David, Councillor Latham. We will then reply to an email. But I apologise for that. We are always available. It just might be that the technology is not always linking in.
Philip.
Thank you, Chairman. I'm pleased to hear what Nick's had to say about wider scrutiny and scrutiny of ourselves, because I've been concerned for quite a while that it's been concentrating on the NHS too much. There's enough people scrutinising the NHS. We scrutinise the scrutineers, a bit like the police and crime panel. And that was one of the things that came out of the Francis report. Although I wasn't interviewed, I read the thing from one end to the other, and understood that one of the problems in that area was that scrutiny at district and borough and county were confused and who was looking at what. Meantime, the hospital carried on doing what it was doing, and they had lots of people to look at it. And so I've got the scars on my back too. But I think just on the scrutinising public health in its widest thing, I've got 2 or 3 things that instantly sprang to mind. One is the leisure centres and gyms closures through the pandemic and people's health. And I do know that our district colleagues have got issues about their revenue funding and the loss to how they're going to run their leisure centres looking forward. But also that some of the, and it might just help the district, some of the organisations that run it and the furlough have gone to the districts and said, we want X tens of £1,000s worth of cash and we want it now, otherwise you can have the lot back. So there's something around that we should be looking at. Just for information, I'm a Vice President and Trustee of the Campaign for the Protection of Rural England, Staffordshire, and they've got a little bit of a project ongoing about the Staffordshire Way. And I mentioned this to South Staffordshire College. It fits in with the countryside stuff there. A project like that, although you'd say, what on earth's that got to do with health? Well, you know, walking does help. And it also helps the economy. So you can be quite cross-cutting in some ways. And I think, you know, there might be something around that. And then locally, on my own patch, there's a quarry. And this is a bit more of this cross-cutting work. The afterlife of the quarry is going to be a sports facility, which is going to, Staffordshire Football Association will run. But obviously these projects are very complex and need somebody to take the lead in it, to deliver it. And you've got all the diversions of, well, we don't want to walk out of town, we want something a bit closer, or who's going to use it. And sports clubs are very good at organising fixtures, but not very good at organising the construction of football and cricket pitches. And so there's something about encouraging that this committee could do, encouraging these bodies to deliver on a project that in essence will deliver ex-football pitches and etc. that will help the health of young people and older people looking forward. One of the things the Health Committee did right when it was set up in 2002-3, and it just triggered my mind. I had a most wonderful title. It was the Junior Vice Chairman of the Health Scrutiny Committee. And we did some work with schools and healthy schools, and how do you make sure that they're fed properly, the activities that were going on in schools. And there was lots of outreach work going on about organisations. Some schools used it as a badge that they collected badges like mad and put them above the door and saying we're a healthy school. But it was a lot of work and a big report. And I'm sure that there's work around that we could be looking at, because there's good practice in some schools that should be shared, putting it bluntly, and what we can do is help share that good practice.
Thank you, Philip. Before I bring Charlotte in, just wanted to come back on a couple of those things. First of all, I think you make a very good case for why we need to be looking at health and well-being. Because in the end, there is lots that we can all be doing to make sure the first day when we get to the front door of that hospital is 10 years later than it could be today. And I think that's the point you're making. And I think you also make a really good point about the role between the county scrutiny as well as local district scrutiny. And I think that there needs to be a much closer relationship between this committee and district scrutiny, if only to make sure some of that stuff is done at the right level, whether it is a local issue or a county-wide issue. And I think that sort of is a good demonstration. And we must add value rather than want to kick the door down. It's more one of saying, actually, how can we help everyone in the whole integrated journey? The third bit I just wanted to say is there is also that role of working parties, and we must take that opportunity. You know, one of the things we haven't talked about so far today is healthy life expectancy. You know, we spend too much of our time banging on about life expectancy, and actually the sadness is that whilst we're extending, we've stopped extending life expectancy, but whilst it's static, actually most of the gains have been in unhealthy life, and that's not what necessarily I think our residents want. So thank you for that.
Can I just come back? Yeah, there was a couple of things. One is that whereas we've got quite a good scrutiny department, a lot of the districts have just got one officer who covers a wide range of things, so we're here to help. And I think that's key. And the other one was that when we did the healthy schools bit, we worked out that you could actually measure things by the weight of chips that were ate in schools, whether they reduced or not, which Derek Davis, because he used to love chips, had a go at me, said I was having a go at him, but no, I wasn't. But, you know, that was some of the work that was going on. And I think there's an honest synergy. You know, we're not taking over the districts. It's just here to help, but parks and swimming pools and all that, we're all part of that healthy living. And you're quite right. It's trying to keep people healthy for that little bit longer. And it's not, you know, hospitals are great. You know, they do a good job, but we've just got to keep people out of them.
Thank you, Charlotte.
Thank you, Chair. I really just wanted to make the comment about the difference between district and county scrutiny, at least in my experience within the Staffordshire Moorlands. Because and it may be different in other districts, so I apologise if that is the case. But I think what the county scrutiny process tries to do, and indeed the parliamentary process as well, is to make recommendations. But I fear that, although this shouldn't be the case, that mostly in district and boroughs it's about receiving reports and occasionally scrutinising people who come to the committee to present those reports. But in general terms, recommendations are few and far between. And I think that's unfortunate, because if we are dividing scrutiny between the sort of county-wide and the local, it's really important that we make recommendations both at local level and at county level. I very much agree with Nick about the fact that we haven't scrutinised our own health portfolio, social care and so on. Obviously social care in terms of care homes and so on is on the agenda, or has been on the work programme, but for various reasons during the pandemic it wasn't taken, but really glad it is on the work programme. But one thing we haven't looked at is the Health and Wellbeing Board. I don't think we've ever scrutinised that. I don't think we've ever had a report about the Health and Wellbeing Board. We did have an early discussion about it, and the fact that you didn't have in the same room the purchasers and the providers, which I think is a major weakness of the Health and Wellbeing Board, because when we did have a session where we had both the providers and the commissioners of service, that was actually quite a productive session, because we actually had them face to face rather than you know, ducking and diving their responsibility. So I think that's important. And the last question would be, are we the only scrutiny committee that meets in August?
Let me pass over to Nick for some of those, and I'll pick up the balance.
There's quite a few issues there, Councillor Atkins. I'll try and pick them up. If I miss something, I apologise. If I pick up the first one that I can respond to easily.
Say Councillor Charlotte Atkins, because otherwise we might have some confusion.
Yes, I apologise. Councillor Charlotte Atkins, yes. Actually, I was drafting a set of minutes the other day and I had to keep putting a C, make sure that we got the right Councillor Atkins. So, with regard to the Health and Wellbeing Board, yes, it is within your remit as a health and care overview committee to scrutinise their operation. I'd have to check on the date. They were called in a few years ago to actually say what were their outcomes, what had they delivered as a body, and it may be when you head into your work programme planning, you might want to put a date on your calendar as a committee to call them back in and say, actually, as a board, what are you delivering? What are your outcomes? So they definitely have, Councillor Charlotte Atkins, been held to account, but it might have been a while ago, I will admit that. With regard to, I'm trying to think of all the points that you raised, Councillor Atkins. So with regard to...
Recommendations, social care, which is on the work programme, or hopefully will be on the new work programme. I'm not suggesting the old work programme would automatically go over. And then do we meet in August?
Yeah, so with regard to adult social care and the services that we deliver, that is, as part of member-led scrutiny, up to you as a committee. I hope you raise items that you have concern on. I'm sure Dr. Harling, who's online, will be able to respond. But if you've got adult social care, public health issues that you want on the work programme, definitely that would be, this is the time to start that process. And then you raised an issue, didn't you, Councillor, regarding district and borough? Do you want to, sorry, Chair?
Thank you. And you also remind me that we let Dr. Harling get away without introducing himself this morning. So when he comes to speak on the next item, we will ask him just to do that piece. And apologies, Richard. So 2 points I want to pick up. I've already had a number of conversations with Dr. Harling about the forthcoming CQC of social care. So going forwards, the county's social care will be subject to a formal review by the CQC, and as part of that he would welcome greater scrutiny. And I think it's exactly the right point that whilst we were focusing on the peak of the pandemic and the importance of the vaccine rollout and all of those important things, and it was right to do at the time, it's time now to get back onto all the other stuff that we also should be doing. And I would certainly welcome that being on the work programme. Second of all, I think what Nick's talked about is our role as individual ambassadors. We're all linked to a local scrutiny committee, and there is that golden thread between this committee and district committees. And I think we need to take that role to encourage and enable people, and to look at best practice across other districts and boroughs. Just because one does it one way doesn't mean it's necessarily best practice. But I think if we're going to get the maximum value out of all of these people being in the same room, we need to be clear who's doing what, because that was a key outcome from Francis. And I would encourage everyone to read the summary of Francis. It only runs to 125 pages.
Someone can borrow my copy if they so wish.
I could send them the 3 online versions, the 125-page summary, and then the 2 big documents that go with it. But I would encourage people reading it, even if it's just to try and pick up the key themes from there, because it is important that either we don't not scrutinise something within the remit, and bearing in mind we're talking about the whole of social care and health. It's a huge, vast area. If we're not careful, we can't scrutinise everything all at once. So I think it's really important that we decide what adds value to scrutiny and what doesn't. And we'll come to that on the work programme. And I think if we did that, then we'll be a lot further forward. Anne.
Thank you, Chairman. I just wanted to mention, actually, I listened to the health and wellbeing meeting last week. I found it very, very interesting. So for new members and that, I think it might be an idea, Nick, if you could possibly give us the dates for the next health and wellbeing meetings, and if anybody wants to listen into it, it's quite interesting. Thank you.
Chair, through you. The next Health and Wellbeing Board meeting is on the 2nd of September, and there are also other health overview and scrutiny meetings within August, Councillor.
Just to respond to the councillor's question, we don't have within Staffordshire a summer break, so the scrutiny committees carry on, and as it happens, we have an overview of scrutiny health and care committee in August. If members feel that will not be well attended, then we will work with members on that. The final point is a point that Dr. Harling's just raised with me, is actually the legal requirement to consult with the committee on NHS to substantial variations does not extend to public health and adult social care, and he just wanted to make that clear. So there is a substantive requirement for the NHS to consult. There is not a substantive requirement for public health or adult social care, Chair.
Thank you. Sorry, Jill, I was going to move on. I'm going to bring this item to a close after you, Jill.
Thank you, Chair. I was just going to point out that with people, I think they call it a staycation. And Staffordshire is a very popular place, a very beautiful place to visit. I think it will be very important that we meet in August, because we're going to be probably having the beginnings of reports from the NHS of an overburdened service and how that's actually going to be dealt with. That was just my point. Thank you, Chair.
Thank you. Just before we move on to item 5, just want to pick up one other point, which is the slides from today's presentation will be put online, and I'm keen that we build a library resource centre for us all to be able to go back to. So, you know, if there's anything you're unclear about in 6 months, you'll be able to find that, because that's where it will sit as a central resource for all of us. We will also start populating that with things like the JSNA, which gives the data behind health within Staffordshire, some acronyms, definitions, KPIs, and other reports, because I think it's really important, I'll come back, I think it's really important that we're able to access things easily, and we understand in detail what we're talking about. Thank you. Is this relating to item 4, or can we go on to 5? And pick it up as part of 5.
I just wanted to know if these slides would be emailed out to each member as well. That would be useful.
Yes, they will, but they'll also go onto this resource centre we're creating. I don't know when the resource centre will be up, but we'll let you know.
Thank you.
So, moving on to item 5. This is where actually we see the health side and social care side of what Nick's been talking about in more detail. And it also picks up some of the things that Philip and Charlotte were talking about, because as ever, they were slightly ahead of the agenda, but we'll come back to that, no doubt. So in terms of these slides, Debs, do you want to just put them up and move on to the second one? So you've already seen through the papers that have already been submitted through the committee papers, much of this, and you will have had the opportunity to read that. So in terms of these slides, you know, just to recap, we have a statutory role to play here, and it's important that we do focus on both public health as well as the GP and secondary health side of things. Thanks, Debs. And, you know, our job is to make sure that we scrutinise both the council as well as the other bodies that form part of it. Having said that, some of the health landscape is in a major state of flux at this moment in time, because there is an encouragement following the pandemic to actually integrate care and work as partnerships more closely. And one of the things that historic members on this committee will be aware of is the launch of the merger of the 6 CCGs across Staffordshire into one, and then from there the launch next April of the integrated care system, which will then involve a range of integrated care partnerships which go from there. Don't really intend to talk about those today, but I'm sure our health colleagues will do. But the point being that there will be a time to scrutinise some of these things. If they're going to be changed by national statute, there's not much point in us scrutinising them too early, because I don't think there will be a shortage of things for us to scrutinise. The point is also that I think there are a variety of ways of scrutinising elements, and we'll come on to that later in the presentation, because I think what we've done a lot of is bring people in front of us, ask a range of questions, but not really sort of dug beneath the surface or focused in on specific areas of those elements. And that might require us to do a bit more deep dive work and be very specific about what element we want to scrutinise. But as you can see there, it's a wide range of elements. I think that allows me to bring in Tracy and her colleagues. Tracy, are you going to drive this from here and bring in whoever it is you want to bring in?
I think Marcus is probably going to go first, and then followed by Simon Whitehouse, so if that's okay. And if I think Deb's in control of the slides, if she can move them forward when instructed. Thank you.
If you put your thumbs up to move the slide, then that will happen.
Brilliant. Thank you, Chair. Thank you, Tracy. So I'm just going to take the first one and run through these bullet points, then hand over to Simon to do the next two. Firstly, thank you very much for the opportunity to do this as a hybrid meeting. As someone who spent half his time before the pandemic driving across Staffordshire and outside of Staffordshire, the opportunity to do this from home is really, really welcome. I think Nick gave you a pretty good flavour of the NHS locally and our commitment to you as an NHS family from a scrutiny perspective, so I'm not going to say too much about that. The Chair also talked about some very significant changes happening nationally around the way the NHS is organised and where various responsibilities sit, so we'll just give you a flavour of that. The NHS in Staffordshire is largely split into commissioners and providers, the commissioners being the 6 clinical commissioning groups. As the Chair said, we were encouraged, as all CCGs were, to merge on the basis of integrated care system footprints. We did have a vote at the beginning of the year, and our GP practices, our member practices, of which we have 147, did actually vote to merge by a majority of around about 84%. Voted to merge. Because of the impending legislation around integrated care systems, there will be no more CCG mergers. So therefore, we're devoting the time we would have spent on merging to working with system partners, including the local authorities, around the creation of the integrated care system, the ICS. What we do have, and we did this in 2017, 2018, is we only have 1 accountable officer, that's me, rather than 6 for the individual CCGs. We have 1 executive team. At the back end of 2017, we went from over 20 directors down to 6 executive directors. We have a single management team, and we had a management and change process for that in the first half of 2018. So actually, a lot of the benefits of having a single CCG we've already delivered through streamlining our arrangements. So whilst we have 6 governing bodies, they do meet in common. We do share some of the roles across the CCGs, both executive, clinical and lay member roles. And we do have all of our committees meeting in common. So rather than 6 CCG finance and performance committees meeting, we do that once together collectively. So a lot of the benefits of merger, not least the savings of running costs, we've already delivered that through what we've done over the last 2 years. And I think it's fair to say that we're well placed to make the transition from CCGs into an integrated care system. We also have provider organisations. Our main acute provider is the University Hospital of North Midlands, with bases in Stoke and in Stafford at County Hospital. But I think Staffordshire and Stoke-on-Trent is, if not unique, fairly unusual in that around about half of our acute activity, people who need to go to hospital for an operation procedure, for cancer services, for a diagnostic, or just to attend for an emergency appointment in A&E, they tend to go outside of Staffordshire and Stoke-on-Trent. And whilst Queen's Hospital in Burton is within Staffordshire, it's part of the University Hospitals of Derby Burton, which is part of the Derbyshire Integrated Care System. So we do actually, as well as managing flow within Staffordshire across our providers, have to manage significant flows outside of Staffordshire. And that means working very closely with neighbouring systems in terms of the care and the services that our residents receive. Our main community provider is Midlands Partnership Foundation Trust, which also delivers a range of services in Shropshire, and they also deliver mental health and learning disability services in the south of the county, and in the north we have combined healthcare, North Staffordshire Combined Healthcare, which is our mental health and learning disabilities provider in the north. So there's been quite a lot of bringing together the commissioning and the provider side, so we have fewer organisations and streamlining arrangements and reducing bureaucracy. There will be more of that as we move towards an ICS. Another important point to make is that the legal responsibilities for consulting, involving and consulting the public on any major service changes actually currently sits with the clinical commissioning groups, with the CCGs. That will become the responsibility of the integrated care system NHS body, assuming the legislation navigates its way through the House and becomes statute. And all the other responsibilities that currently sit with the CCGs, our statutory responsibilities, will also be assumed by the ICS NHS body from the 1st of April 2022. So as the Chair said, there will be some fairly significant changes to the NHS landscape nationally and across Staffordshire and Stoke-on-Trent. The relationship with the scrutiny, overview and scrutiny committees is really, really important, and Nick set out the very significant responsibilities that overview and scrutiny committees have. And we were reminded of that a few years ago, where we were referred as CCGs by both the Stoke and the Staffordshire Scrutiny Committee to the Secretary of State, who then made a referral to the Independent Reconfiguration Panel around some changes in community services in the north. And the IRP felt we hadn't actually properly engaged and consulted on that. Thankfully, by the time we got the recommendations back from the IRP, we'd actually done what they would have asked us to do anyway. But it was a salutary reminder that we cannot take any shortcuts around how we engage our statutory partners and our public in any significant changes that are to be made in terms of service delivery across Staffordshire and Stoke-on-Trent. And also, as Nick said previously, it's up to you to decide what we should be engaging and consulting the public on. That's not a decision for us to make. Tracy works very closely with the Chair, with Nick and his team, in terms of these are the things coming up that you may want to have a look at and to call us in to scrutinise. And I think that relationship, Chair, has actually worked really, really well with the previous committees and also with yourself. Simon will talk a bit more about the priorities, etc., that we will be talking to you about over the course of the year. But one thing to flag front and centre is that we did pause pre-pandemic a very significant consultation on the configuration of services across Staffordshire and Stoke-on-Trent, part of the Sustainability and Transformation Plan. And now that we are now beginning to sort of get back to business as usual, we will be picking up the areas that we were consulting on and that consultation process over the course of the summer. And obviously you will want us to come and talk to you, no doubt, around what that very significant change programme is composed of. Things like the configuration of the urgent and emergency care system, planned care services, maternity services, not least the freestanding midwifery and birthing units, of which we have one at County and one in Lichfield. And also mental health services, for instance, the future of the George Bryan service in Tamworth and the services that delivers. So a very, very big and challenging set of proposals that we'll be consulting on over the remainder of the year. And then finally, the white paper, which was published earlier in the year, which will, I think the legislation is currently being drafted to create integrated care systems, will be the most significant reorganisation of the NHS since the Lansbury reforms that resulted in the Health and Care Act of 2012, which will have significant implications for me, for Simon, for the providers across Staffordshire and Stoke-on-Trent. And again, as the Chair said, something that no doubt you'll want us to come back and talk to you about over the course of the year once those proposals are firmed up. I think one thing I would say is I am the accountable officer for the 6 CCGs. My relationship with both scrutiny committees in Staffordshire and Stoke I take very, very seriously. It's not something that I delegate. And when asked, I do attend in person. I tend to continue doing that as we navigate through a year of very significant change. not only are we still working our way through the pandemic, standing services up, delivering a very significant vaccination programme, but we will be going through a very significant period of change and also driving some of the changes in the way that care is delivered across Stafford and Stoke-on-Trent. So I think there will be an awful lot for you to get your teeth into, and I do envisage myself making very regular journeys virtually, hopefully, to the committee over the course of the year. Hand over to you, Simon.
Thanks, Marcus. And just to follow on from that and recognise also, agree with what Marcus said, Chair, in terms of the hybrid approach and locking in some of the learning that we've had from COVID in terms of how do we do some of this differently and make sure we carry on working differently. In terms of priority areas to help inform the work programme and the plan for the committee, I think there's a few things for us to pull out really. When we talk about priorities and we link that with restoration and recovery of services, I think we just need to recognise the scale of change that's happened to a number of services over the past few months as they responded to the COVID response, both the closing down of some services, the fundamental change to the way those services are delivered. I think what's really important is we recognise that services have continued to be delivered over the past 12, 18 months. So we hear a lot in terms of the services stopped operating. I'm not aware of any that have stopped formally in terms of the way they deliver services. They deliver services differently. The way patients and local residents access them has changed fairly fundamentally, but there's still been the ability to access those services, although it might not have been how people have experienced it previously. So in terms of that restoration and recovery, I think there's a really important element here, which probably isn't mentioned on the slide explicitly, but it's about workforce, it's about staff. Recognising the way that staff have responded and worked over the past 12, 18 months and making sure that we can support staff to recover as much as we recover services and that we support staff through the work that they're going to need to deliver going forward, because the demand and the expectation on staff is going to be really significant. We need them to be able to deliver services as we bring that renewed focus over the next few months. From a system perspective, we've agreed a few areas that will be high level for areas of focus going forward. Frailty being one of those, health inequalities to which COVID and the vaccination programme have absolutely shone a light on being one of those. System transformation and system savings, and Chair, in your introduction you referred to some of the financial challenges that the NHS has across Staffordshire and Stoke-on-Trent, but recognising that the way to respond to that financial challenge is building on the transformation programme, building on the change programme that Marcus has touched on, and as listed on the slide, the recovery of services. Primary care in terms of GP access will be a key area of focus going forwards, as will how do we make sure we've got the right focus on the right secondary care services. But delivering outpatients in the way that outpatients was delivered previously isn't going to be something that we should be saying we need to get back to. It needs to be how do we embed the changes that we've seen in a way that best meets the needs of the population and the healthcare needs that we're following through. Marcus has already touched on maternity. The review that took place, the Ockenden review that took place and that was published as a result of what happened at Shrewsbury, absolutely will have issues and will have implications for the way we deliver maternity services across Staffordshire and Stoke-on-Trent. The NHS reform bit, and again you touched on this, Chair, right at the start. You were really clear in terms of saying you don't want scrutiny to be on structures, and I think that's absolutely right. The scrutiny needs to be on making sure that we're delivering the outcomes for the population that we've got responsibility for, and we do that across a range of services and a range of areas where you're going to use those dashboards and those areas that Nick talks about to bring a focus to. But let's recognise there's going to be a period of change and a period of movement, and during that time we need to make sure we've just got the focus in the right areas. And as per the conversation and the headlines that Marcus touched on previously, we want to make sure that we're as transparent as possible whilst we're going through that change. But the focus needs to be on how do we come out of the COVID response in a better way that meets those health inequality challenges that were really clear still exist across Staffordshire and Stoke-on-Trent. Next slide, please. And some of this feeds into this. So in terms of challenges, I've touched on staff in terms of the impacts of the pandemic. I mean, you know, the vaccination programme that you're going to hear about shortly, absolute success in partnership working in terms of the way colleagues have worked together. But we're going to need to talk about how does that become business as usual. We can't pull significant numbers of staff out to do the vaccination programme that have an impact on other services if we're going to have to continue delivering the vaccination programme and some form of booster programme over a period of time. We've touched on financial recovery and the scale of that, but also I think there's a flip side to the financial recovery, which is wider than just the NHS challenge. The NHS absolutely has a responsibility as a large employer to be playing its part in the socio-economic recovery as we come through the COVID pandemic. So the financial recovery in its widest sense here is something that the NHS organisations have a role to play. And then I guess the final bit, and then really keen to get into the conversations, I think, is when we talk about workforce recruitment and retention, and we talk about some of the challenges that change into the integrated care system will bring, I think there's four main areas that the ICS will have a clear focus on, and indeed will be given a statutory responsibility to have. First one of those, improving outcomes in population health and healthcare. The second one about tackling inequalities and outcomes in experience and access to services. The third one is about enhancing productivity and value for money. And the fourth one, making sure that the NHS supports the broader social and economic development. And I think I've touched on those through these past couple of slides and through focusing on the priority areas that we're going to bring about. But we just need to make sure that health scrutiny, the integrated care system, health and wellbeing boards, NHS organisations, voluntary sector, local authorities continue to build on the partnership working that we've seen over the past 18 months to really tackle some of those outcomes and health inequalities that we know are not doing the best for the population of Staffordshire that we should be doing. Next slide, please.
Simon,
Chair,
I think that's the end of your slides, but certainly I just want to say a couple of things before I move on to Richard Harling, which is thank you both Marcus and Simon for those comments. I think they set a scene. I think they are quickly said, but there are many years worth of conversations we could have around those in much more detail, and that's really why it's important we touch on those for members of this committee to decide which bits we do. I particularly associate with the comments about staff. The last 15 months have been horrendous for many working across the pandemic, whether it's in social care or in the healthcare system. And actually, when you talk about a period of change, there is a significant job to take to lead them through that as well. So thank you for that. Let's. Can I pass over to you, Richard? Now, do you want to do the introduction you should have done about a few hours ago, and then just talk us through your slides, please?
Thank you, Chair. So good morning to committee members. I'm Richard Harling. I'm Director of Health and Care for the County Council. Just 3 slides this morning to help to give you a flavour of the County Council's public health and adult social care functions. Our responsibilities are given to us under the Health and Social Care Act 2012 and the Care Act 2014. They first of all involve health protection, and what we mean by that is protecting the population against communicable diseases and other non-communicable threats to health. COVID is the most obvious example of that. It also includes other infectious diseases like measles, non-infectious threats, so things like environmental hazards, and assurance of things like vaccination and screening programmes. Secondly, health improvement and promoting well-being, and we try to do that both by influencing the environment in which people live and also people's personal behaviours, so for example smoking, diet and exercise. We then have a statutory duty to assess people's needs for care and support under the Care Act, and eligibility is determined by a combination of their own circumstances and their financial means. Where people are eligible, we have a duty to meet those needs in a way that is appropriate to the individual, but also cost effective for taxpayers. Fourthly, we have a duty to safeguard adults at risk from abuse or neglect. These will be adults who do have needs for care and support and are typically the most vulnerable and frail adults in our communities. And finally, we have a duty around managing the care market to ensure that where people do need services to provide care and support, that those are available at a price that taxpayers can afford. If you could go on to the next slide, please. So in terms of our priorities, we have a series of strategic objectives in health and care, and they are, first of all, to protect the population from COVID and other threats to health. Secondly, to build a healthy Staffordshire with an environment and communities that promote well-being. Thirdly, to offer extra support for those people who need it, to maintain their health and independence and get them back on their feet at times of crisis. Fourthly, to safeguard adults with care and support needs from abuse and neglect. To maintain long-term care services so that when people do require care, there are quality services available at an affordable price. We then need to do all of this within the resources available to us. So that is the budget we are set by the Council in the medium-term financial strategy, plus a variety of sources of external income. And then finally, we are keen to do more to showcase some of the good things that are going on in Staffordshire. Particularly during the COVID pandemic, there are lots of examples of good practice, and we're quite keen to let other people know about them. Final slide on challenges. So first of all, the ongoing pandemic. This virus will be with us for many months and years to come. We will be managing successive waves of infection as new variants emerge. Hopefully those waves will not be as severe as what we saw in January this year, especially if the vaccination programme continues to make excellent progress. But certainly the County Council envisages maintaining a series of COVID defences for at least the remainder of this financial year and possibly more longer term. Secondly, there will be a longer term impact on health and well-being arising from the pandemic. That may be a direct impact from things like long COVID, but also the indirect impact, the consequence of people spending long periods in isolation, the damage to people's education and employment. All of these will have an impact on health and well-being that we will have to respond to. One of those may be that translates into rising demand for adult social care. So we plan the budget on the basis of the anticipated demand. If it rises above that, the risk is that it gives the council an unsustainable financial pressure. The sustainability of care providers is a real risk. In actual fact, during the pandemic, providers have done a lot better than we expected, but there are some very real risks longer term because they need to maintain stringent standards of infection prevention and control. They are going to continue to struggle to recruit, particularly if the economy recovers, and there are some very real cost pressures. And finally, all of those add up to a funding challenge. You will have seen nationally the debate about sustainable funding for adult social services. The County Council has set a balanced budget for the next 5 years, but there are risks to that in adult social services if either demand or price rises above the predicted levels. So we will continue to lobby government to ensure that funding is commensurate with demand. That's all from me, Chair. Thank you very much.
Thank you, Richard. And again, very much a whistle-stop tour of a lot of very significant issues with a lot of significant potential impacts to residents of Staffordshire. So thank you for that, and I'm sure we will add a lot of these to the work programme. So before we actually talk about the detail of the work programme, and I've got a proposal in terms of what we might want to look at over the next couple of months, just as a starting point, is just to give some pointers in terms of how we might want to think about the work programme. So what I think we need to be looking at is what needs to change, what needs to improve. Actually, when we need to be doing that scrutiny of that element, because actually there are a lot of complicated moving parts to this machine, and we need to make sure that we don't do something too early, so that we actually haven't done some of the consultations, for example, or alternatively that actually the decision's been taken. Not that the decisions can necessarily be taken, but we need to make sure our timing is right. We also need to take the opportunity to shape policy and influence some of the pre-scrutiny discussions, using our own experiences, using what we understand is happening within our communities. And we need to make sure that this is member-led scrutiny, and in the end, you are the people who decide what is on the scrutiny programme. Thank you, Debs. So there is a variety of different ways of us fulfilling our obligation in terms of scrutiny. There's lots of information. We'll put some of it out into a library. I would encourage you to go to that library and force yourself to read some of it, because the problem with a mountain of paper is, and I'm sure we all see the same thing, is sometimes it's nice to have a night off. But I would encourage you to dig and invest in time. The scrutiny will be better, the outcomes for our residents will be better. The more we understand certain areas and elements, the more knowledge and experience we will bring, and the more value we will bring to our residents. And you'll see that also rippling through into some of the work in the districts. There are things like, Health Watch surveys. There was one referenced at the Health Wellbeing Board last week. There are lots of annual reports that Health Watch has done. We should access some of those and pick up some of the knowledge and insight in there. But equally, there are a whole range of other things that we can do rather than just looking at scrutiny as a sitting around the table and scrutinising an issue through a question and answer series. So, for example, we can use thematic scrutiny, whereby we look at a specific topic and focus in on that topic until we're satisfied that we've got underneath the surface of the discussion. Equally, there are a range of other things, whether it's through triangulation, and obviously members, the beauty of some of the stuff that we do is that you are in certain situations and circumstances, whether it's in terms of locally in the districts, or alternatively in your casework, or what you see out as individuals, because we all consume health services and well-being services ourselves. I'm making no personal comment out of that either. But we are consumers, and actually, if what we're consuming and seeing, if what we're seeing in our casework, if what we're seeing doesn't ring true with what we're being told, then we have the right and we have the duty to really get under the skin of some of that. And looking at, for example, quarterly complaints monitoring, is something that we could do more of. We could attend more of some of the Health and Wellbeing Board meetings, some of the meetings of the Shadow Board of the ICS. Thanks, Debs. Really the whole point here is about trying to add value to the scrutiny that we're doing, because I think we're all after the same thing, which is we want to make a tangible difference to the health and well-being of our local residents. And I don't think there is much more to say about that slide than exactly that. So let's move on. And we've obviously talked a bit about some of the ways of doing that. Some of the bits we haven't talked about is inquiry days. Actually, we're 10 years on from the Marmot Review, and we've not made any progress on health and well-being in the grand scheme of things, and healthy life expectancy. And actually, one of the things I would welcome is that opportunity for us to bring in a variety of people to have those discussions. And equally, there are opportunities for us to hold individual specialist briefings, and I would suggest that with the impact on mental health from the pandemic, that we actually look at trying to understand that whole area in better detail. And the purpose of doing that is that we often talk about mental health, but what do we really mean? Do we mean acute, or do we mean actually some loneliness and isolation and depression? And that's why I think it's really important that we dig beneath those surfaces. Thanks, Debs. So I'm going to leave this sort of checklist up, really, if only to try and open up the debate for members now to say what you would like to see on the members' programme. We have a proposal that is an outline today, which we could talk about, but I prefer to open up the floor first of all. Charlotte.
Yeah, very much picking up Chair, on the points you were making about... Sorry. Oh, okay. Yeah, really picking up, Chair, on what you were saying about the impact of the COVID pandemic, because I think it's very easy to lose sight of a range of issues, but particularly, I think, on mental health. Now, my concern, and I have to say that I'm visiting a project this afternoon, is about community mental health. You know, I don't want to see people locked up in, not locked up, but, you know, in hospital wards. I want to see people their well-being being promoted. And I would like to see us look into community mental health projects, ones which are based in local communities, ones which take on board the importance of being in the open air, communing with nature, being involved with creative activities, those sorts of approaches to mental health, rather than the, you know, acute psychiatric type approach. And the second area I'd like to look at, because I think it's often just completely neglected, and actually it has a huge impact on children, on mental health, on well-being in general, which is in fact dentistry. Now, dentistry is part of the STP. It was added as an extra line within the STP somewhat after the original plan, but it is an important plan. It is an important part of the plan because if you're looking at obviously prevention, that's really important, and I think that I'm picking up a lot of issues around routine dental assessment not being carried out. I'm also picking up the lack of access to orthodontics and also to consultant dental practitioners. So I do think it's a whole area which we could look at and really just question the STP about what is happening there, because I do know, and I should declare I'm Vice President of the British Fluoridation Society, that, you know, we do need to look at the whole area of dental health, because, you know, it can have a huge impact on people. If they're going for a job interview and they've got black teeth, you know, they're not going to feel confident. Or if they're doing anything which involves social interaction and they've got gaps in their teeth and so on. So I do think it's an area which we haven't looked at for some time, and we do need to look at in terms of the new, it's not new anymore, but the ongoing dental contract and so on, which I think we want to pick up on the preventative side rather than just the extraction and filling side. Thank you.
Thank you, Charlotte. Before I bring anyone else in, Simon.
Thank you, Chair. Just coming off mute, I think, so just to respond to Councillor Atkins, I think absolutely spot on, Councillor, in terms of the dental agenda, and I guess that it was very broad, but that gets picked up under the health and equalities piece, as you talked about, and links to the prioritisation piece in the white paper that was published, with a really clear focus on fluoridation and the preventative agenda from a dentistry point of view. In the short term, that remains commissioned by NHS England and NHS Improvement, so it's not commissioned locally. The proposal is, and I'm sure Lynn Miller, when she talks, can pick up on some of this in more detail, the proposal very much is to transfer that as part of the changes to the NHS, but I think it's an absolutely a primary care access piece. For me, primary care is about dental, optometry, community pharmacy and general practice in its broadest sense, not just about general practice, and that would be appropriate to pick up, and we've already started some of those conversations with local dental colleagues.
Thank you, Simon. Can we leave that where it stands and come back to it when we look at the overall programme? Let me bring in Keith.
Thank you, Chair. My comments are generally more generic than being specific about certain services and things. I do think that with such a wide agenda and us not being directly in control of many of this, is that we do need to target what we scrutinise and, as you say, when we scrutinise it to make maximum impact. And I think that's going to be a skill that we're going to have to try and change, particularly after the COVID. I think we're going to have to be far more pinpoint where we need to try and do this sort of work and how quickly we can do it. Because obviously the longer we take to do something and we find out there's an error in it, then there's people going to be suffering as a result of us not being able to come back to the committee and then send out recommendations. So I do think it does need to be targeted far more precisely than perhaps it has been in the past, where it's quite wide areas have been covered. I also think the idea, you mentioned triangulation and all the rest of it, I do think we probably need to go further than that, and I know that we are looking at districts and everything else, and we're part of this committee, but those people that aren't there at the moment are the parish and town councils. They want to try and bring in some services and also provide some support. They did it really well during the pandemic. It's something that we picked up on, as you know, through previous work that we've done, and I do think that that's something else that we need to try and bring in, so it's not just within the normal remit of what we have done in the past, which is the NHS, the providers and everything else. If we're really going to get into the community and have support and be able to take people on the journey with us, as it were, we're going to have to really push that forward, and hopefully the NHS and other service providers within their work will want to try and do that. So they're the two things I think we need to try and do to make the most out of what's happened during the COVID pandemic, and also to try and make sure that we get those results and those actions happening quickly. I'll leave it there.
Thank you, Keith. Let me move to Janice.
Thank you, Chair. Just a couple of things before I go into some of the items that I've been considering. Firstly, thank you very much for the preparations for today. As a new member to this committee, I would say recognising the breadth and the scope is something that definitely identifies the priorities in there, and I would say could potentially be overwhelming in some instances as well. So it's been useful having that preparation in advance, and I certainly look forward to gaining a greater understanding. As far as what's being communicated to me, certainly in the run-up to being in this position today, would be accessing GP services, and I certainly have an appreciation of the challenges, and I use that term loosely as to recent times. My question is to look at, do we consistently measure and publish locally that information of being able to access GP services, and how we can direct and signpost people to that? Is it a problem that's just a phenomenon in City North, which I'm representing today, or is it a wider geographic spread across the county? That would be the most pressing thing that has been highlighted to me as the first one. Secondly is picking up on a comment that Councillor Charlotte Atkins made earlier on. One of the things that I was most interested in looking at is the wellbeing counsellors, and doing something as an outreach operation with a focus on certainly on mental well-being, and how that can be engaged with our education providers. I know historically there's been much debate on having these facilitators within schools and educational establishments, but how that can operate within a community basis, particularly, is one thing I would be looking at. And then lastly, I know the government has made much information of late about the consultation on women's health strategy, and I just wondered what was being done in support of engaging with the female population of our beautiful county, to develop that women's health strategy. Thank you.
Thank you. Now, Marcus or Tracy, do you want to come in on anything specifically? I've got Lynn. Thank you. Lynn, let me offer you the opportunity to have a conversation on the GP access.
Thank you, Chair. I mean, certainly access to general practice is an issue at the moment. I'm sure most of your constituents are contacting you about this, particularly in terms of telephone calls. The volume of calls we're getting is huge at the moment. We do monitor the performance of our practices. We have a dashboard that looks at a range of indicators, which from things like long-term conditions to GP referrals to A&E, antibiotic prescribing, which gives us an indication where practices might be struggling. And we do report through the Primary Care Committee, which is a monthly committee that discusses issues such as access, which is on the agenda in Northern Staffordshire tomorrow, actually. And we do have a live stream to our Primary Care Committee if people would like to join that. What I will say, Chair, is that we've got a programme of work built around improving access, recognising some of the issues at the moment, and in the future, obviously, I'll be very happy to come back and discuss with members some of the plans that we've got in place and how we can engage with local councillors to ensure we've got the right representation of some of the groups that we've got in place.
Thanks for that offer, Lynn. I'm pretty sure it'll go on our work programme, but we'll wait for committee to decide. Just let me circle through a few members if I can. Jack.
Well, thank you very much, Mr. Chairman. I just wanted to raise two issues that you've raised earlier, and they're particularly poignant to my division, and that's loneliness and the issue, especially for elderly members of my division. If there was the opportunity to look at that, I'd be incredibly welcome of it. And then on the second point was the item that you raised on the environment and the fact of climate change and the impact of air pollution, etc., on the health of my constituents. That would be the second item that I'd really welcome of this opportunity to look at. Thank you.
Thank you, Jack. Just on that secondary point, the environment, obviously we can broaden that discussion in terms of the environment to actually looking at climate change and what is the NHS as an employer doing as one of the largest employers in the country. It is an opportunity for us to scrutinise the plans that the NHS locally in Staffordshire have for delivering on the commitment for net zero. And so I think it's a really important point. But I mean, your point was very specifically about air pollution, but equally we should look at both elements. Nick.
Thank you, Councillor. I think climate change is a really important thing for the Health Committee, but I think it goes much wider. So as the Scrutiny Manager, it's certainly on the radar for the Corporate Overview and Scrutiny Committee. So that's the role that the Council, as a large organisation, is playing in the climate change agenda. It also affects our Prosperous Overview and Scrutiny Committee. So I'll take your comments on board, but it may be that we don't scrutinise it in this arena, but it's scrutinised elsewhere, but with health being picked up, as you commented on.
Thank you very much, Chairman. Well, my concern, I think Councillor Charlotte Atkins, sorry, has already touched on it. And this is to do with mental health. And I know that the problem, COVID has affected so many children with their mental health. But it's the acute part of mental health that I'm concerned about. And it's really come home to me in the last week or so, actually, that we have a shortage of children acute beds in mental health hospitals to help these children. Now, this is not something that's just happened. This has been going on, to my knowledge, for at least 30 years. And that is outstanding, to think that in a country of our size that we haven't got the services to help our children that need acute attention with their mental health. We have in this county of Staffordshire, actually, one child sitting in an adult ward in St George's because there's no room anywhere in the country to help these children. And I think it's an absolute disgrace that we should actually be looking at what we can do to help these children. Thank you, Chairman.
Thank you, Anne. A recurring theme in terms of mental health, but I think we also need to make sure we break it down in terms of the very specific bits. Let me bring in Jill, please.
Thank you, Chairman. We've talked about loneliness, but I know that I was part of a working group which Councillor Keith Flunder chaired, and we discovered all sorts of problems with the elderly, with social isolation. And I think if it's ridiculous to say that this pandemic has a silver lining, then you'll have to forgive me for saying it. But the silver lining is that we've failed over the years to identify those socially isolated, not just elderly people, every age group you could imagine. And through the pandemic, because we've had such a huge number of volunteers, particularly, I'm talking about my division, Stone Urban, with the Stone Helpline, people have been more willing to come forward to ask for help. So we've had volunteers helping, but of course now things are getting back to a relative normality and we're losing our volunteers, drastically reduced in numbers. So we have these people now who are shrinking back behind curtains and we're losing sight of them. They are digitally isolated and socially isolated. And Councillor Angela has touched on children. I think my biggest worry is that we're talking about children now who have mental health issues becoming evident within school. It's being identified in school. Parents have had concerns, relatives, carers, but now in school it's being picked up on. And we're talking such a lot about learning catch-up and how important and how much money the government is going to plough into that catch-up, which is excellent. But I think we also need to be aware that the mental health problems that are being picked up now, which are being identified, are going to become acute unless we can really get our finger out and make sure that we've got services and funding to help those children. Thank you, Chairman.
Thank you. Can I bring in Paul first?
Thank you, Mr. Chair. Councillor Charlotte Atkins brought up mental health, and Councillor Edgeler also brought up mental health of children. I think as a committee we need to be very mindful of the targeted work, and Councillor Flunder adequately expressed that earlier. One of the things I would like to see, and I know it's a pilot scheme and it's going to be rolled out to the rest of the schools, but is the information and feedback from the practitioners that are in the pilot scheme that's running at the moment in terms of Stoke-on-Trent, of practitioners in schools, because they'll be ideally placed to pick up the effects of COVID as children are returning to work, but they'll also be ideally placed for health in the family, for picking up health and a wider issue and aspects. So I think, A, that we need to use that tool and bring back and scrutinise what's been the findings of this work that's been done so far, A, to pick up additional COVID-related items for mental health, but also to see and fine-tune where we're going in the journey of rolling it out to the rest of the schools as is planned, that we're hitting the right mark, that the right people are employed in that situation to deal with mental health issues for school children that are being identified at an early stage, so they can be signposted to more acute services. And I take on board Councillor Edgeler's important comment about the acute services. They're not good enough in terms of the delivery for children in our area, and to cite them out of county simply isn't acceptable. Thank you.
Thank you, Councillor. Really interesting in that it sounded like you were very eloquently putting yourself forward for a job as Vice Chair in terms of leading on that piece of review work, and I think that's a really sensible suggestion, but maybe we'll take that as part of the discussion. Richard.
Thank you, Chairman. I'm quite concerned for many years now in terms of diabetes and diabetes and obesity, and in particular the problems with actually children obesity. And I'm just wondering ways whether this committee can be looking at something to try and understand where actually I could probably see things not happening where perhaps they should be happening, because it has been highlighted quite a number of times over the years, but we're not actually seeing, I don't think, we're seeing fundamental changes in our way. I speak from experience of somebody who's overweight and a diabetic, and as much as you think, at some point, you know, what is missing that really is the missing link that actually triggers the change, and I've not yet really come across it yet. So it was just something like that. And of course it does lead into mental health as well, because of depression and so forth from being obesity and diabetes as well. So there's a massive link that needs to be really looked into. So whether there's something we can do there. Thank you, Chairman.
Thank you. And certainly at the Health and Wellbeing Board, my learned colleague Dr. Johnny McMahon referenced there will be more people who die from obesity than from the pandemic, and that puts it into stark contrast. Phil.
Thank you, Chair. Mine is slightly off the wall, Chair, so if it's out of the remit, please correct me and rebuke me as you see fit. One of the things I don't think we've ever looked at is the application system for funding for adult care. And I believe that affects quite a lot of people in Staffordshire. And the reason that this comes up in my mind, because it's quite important to declare an interest, in a sense that I've been involved with this with a family member, and I found it quite challenging. So I wondered whether my experience is the same as everybody else's, or my inability to fill forms incorrectly or quickly is creating a false impression. But it could be that that's not something we look at. I don't think it's anything we've ever looked at before, certainly in my 4 years. But it's quite a vital part of the system, albeit an administrative one. And a lot of whispering going on out there at the moment, Chair, I can see.
Thank you, Phil. Just on that, Richard, do you want to say anything, or is it worth you having a conversation outside of this format, just in terms of whether this is a nationally set process, whether there is any review of the journey done locally, those sorts of questions, because I think that's the point that's being made.
Thank you, Chair. So there are certain aspects of the assessment for care and support that are nationally determined because there are a range of factors that we are required to take into account when determining people's eligibility. That said, we do have a fair amount of discretion in the way we organise those, and we always value feedback from people about how we can make processes as streamlined as possible. So very happy to pick those comments up outside the meeting. Thank you.
Chair, do you mind if I come back?
Yeah, please.
I perhaps didn't explain myself well. I wasn't concerned about the eligibility. I was concerned about the administrative system, which is something quite different. So the eligibility, I wasn't challenging in any way, shape or form. I don't think that would be our place to do that. What I was concerned about is about the speed of the process and just the process itself. So again, it may not fall into our remit, Chair.
Can I just suggest that, Richard, you pick this up after the meeting, and then if we need to look at it as a committee, we can then do so thereafter. Is that an appropriate way forward from your point of view, Richard?
Fine with me, Chair. Yes, thank you.
Thank you.
And fine with me too, Chair.
Yeah, thank you, Chairman. Without prolonging the meeting, because I know the battery will run flat on my laptop eventually. It's something Richard said about schools and obesity, and I mentioned it early on. The Healthy Schools programme is there still, healthyschools.org.uk, and whereas we're not doing it for schools, schools can quite easily join that, register. There's a whole programme, even down to helping resources to support children's wellbeing, education, schools, parents, carers with COVID-19. So there's no need for us to make massive amounts of work. It's just a matter of pointing somebody in the right direction. And one of the sad things is that since schools have become detached and academies and arm's length and all the rest of it, because we're wicked councils that run them into the ground, actually we've got a role now of advising them where the help is, and that is something that we can all do as members. So it's www.healthyschools.org.uk.
And those details will be part of the minutes going forwards. Thank you, Philip. Janice.
Thank you, Chair. Yeah, it was following on from the previous point there about the form filling side of things. I recently have endured some of that process with my elderly parents, and there are specialists now who you can access to be able to just help fill in those forms. Now, I'd consider myself, pretty able to be able to do such things, but Age UK, for example, will provide that facility in the absence that they know how to fill in what can be volumes of paper. So it is a valid point that my fellow councillor is making there.
Just a quick point following on from Phil. I chair Age Concern in Stone, which is an absolutely free service, We have just sent some volunteers on a special course. We've managed to access funding purely to fill in these ridiculously detailed forms, both for blue badges, which you can't apply for other than online, but also for care allowances. And, you know, if you think that you've got to pay for funding to train somebody to fill them in, then the ordinary man and woman on the street's got no chance. So, you know, I fully support what Phil has said. Thank you, Chairman.
And I understand exactly what you're saying, because I think I chaired the group that signed off that funding. So I should declare an interest, but I won't leave the chair, because I don't think I was, it wasn't a pecuniary one or anything else prejudicial. If you're happy, Phil, what I'd like to do is just use the route I've suggested, and then if there's a wider debate, then we can have that wider debate from there.
I'm more than happy. I still think there's a wider debate here.
And I'm quite happy with that. I'm just looking at the existing work programme and thinking that we need to keep that within bounds.
That's your job, Chair.
Thank you. You're all heart this afternoon. Right. So, can I suggest that we go through the... Sorry. Can I suggest that we start with the base that was proposed at the outset of the meeting, and then say, what are we going to take out to be able to slot in? Because otherwise we will never get through meetings, or alternatively we'll have 15 things at the meeting and we won't actually scrutinise it properly. And it's really important we do that job properly, because as you know, it's a statutory function, and Keith.
As you mentioned earlier, you've got 2 vice chairs at the moment. Chair, pay attention. You've got 2 vice chairs at the moment. So you're saying that we won't get to scrutinise some of this, you know, correctly in the meeting like this if there's too many things to be going on. Why don't we identify the things that we could also then ask to be done, if you like, outside this particular meeting, to be able to then start getting in better and more detail, which is what Nick brought up earlier on. So it's just purely a form of I'm sure Nick understands what I'm saying, and you probably do as well, to try and pick out the bits that we need to do work on separately, and then that should shorten the agenda and bring in items we can do within the reporting process, and I'm sure that might help some of the NHS partners as well.
Can I come back directly on that? So we normally have 10 meetings a year. We've now slotted already an extra 2 meetings in, and that's before we start looking at doing any specific scrutiny on any of the other bits and pieces. And before we start doing inquiry days or other bits and pieces. So my suggestion is we do actually scratch our heads and focus, because if we don't scratch our heads and focus, we could meet every week. And I mean, look how often the NHS meets, and their meetings are 3 or 4 hours and 300 pages, and you know, really good stuff in there. We really need to focus, I think, is probably the point I'm making. So shall I just talk through what's in front of you, and then we can decide what we slot in? But let's focus on the next couple of meetings if we can, because I still do want to keep some license, because if there is a resurgence, and no one wants a resurgence in the pandemic, but if there is a resurgence, we need the ability to be able to slot stuff in at relatively no notice if it is of critical value to us. And we also need to maintain a surety that the vaccine programme is not effective, because we know it's effective. We know Staffordshire is one of the leading deliverers of vaccine across the country. But what we do probably need to make sure is that actually we have touched those vulnerable and difficult and most hard to reach categories, which is why it's still on the agenda today. So the bits left on today's agenda is Dr. Hannigan and Lynn Miller talking about the COVID update. But the next meeting is was designed to look at maternity services, because as I think it was Simon referenced, there is a review coming along on maternity services based on the Ockenden review. And I think that is the right time in July to be looking at that detail. Secondly, in terms of the George Bryant Centre, there is a element in terms of mental health. Members will be aware that the George Bryant Centre has been closed for a while, and there is a need just to look at where that, what happens, what the NHS's proposals with that unit is. And then finally, I think outside of the COVID update in July, we should be looking at the future delivery of residential care services in Staffordshire, assuming Richard is going to just nod his head. Because I think that it's part of that comment about we haven't really done enough work on social adults, well, we haven't done enough on social care, full stop. The August meeting was suggested to look at actually some of those recommissioned services, to look at the provision of A&E, to look at the GP access and actually care home services generally. With a further meeting in September looking at mental health broadly. That is to start with an overview of all services so that everyone starts in the same point. Because as I say, the breadth of mental health services is huge. And then to pick up the difficult discussions, consultation that forms part of the STP merger of CCGs. So where within the programme between now and September do we want to pick up some of the points that we've discussed today? I think mental health will come out as a meeting in September, but then there will be many strands of activity from that. So I don't suggest that we try and slot that in and diarise that now, because I think the first step is to do that in September. Obesity, very simply, was going to fit within the wider Determinants of Health Day in October. And I would suggest that it probably is a big 3, 4, 5 hour session, you know, maybe a full day. Maybe we want to split that into various elements. But I think between the vice chairs, we can have that discussion with members and bring that back to the next meeting and make a proposal or two and see what people want to support. And just wait. And in terms of the September meeting, at the end of September, there's a proposal to put a meeting in because there is going to be a new corporate plan from the County Council. And it's really important, in my view, that we scrutinise what the Cabinet members' proposals from the health and care side of things are, so that we can ensure that our comments, our concerns, are reflected in that corporate plan. There's no point in discussing it after the corporate plan's been signed off, after all. What comments have people got? David.
Thank you, Chair. I suppose I have to declare a very strong vested interest in the maternity services, i.e. Samuel Johnson Hospital, which has changed its role greatly, and also the George Bryan Centre, which affects Lichfield and Tamworth. The corporate plan is interesting. We've changed very recently from 4 overview and scrutiny committees at Lichfield District, this is, to 1, which I am now chairing, and it is becoming very plain to me that I will only be able to scrutinise what's on the Cabinet work programme, because there's just too much of everything else to scrutinise for one committee. So I wonder if we should be looking at health. If it's on the Cabinet, if it's on the corporate plan, it's a must. The rest of the stuff comes after that, but we must, I suggest, be looking at what Cabinet at County is doing with health. If we don't scrutinise that, I think we will come unstuck, because that is the way that my committee is going to have to go forward. And certainly basing what Stratford-on-Avon District are doing, they've got 1 overview and scrutiny committee. All they do is scrutinise what Cabinet's working on. They don't touch anything else.
Can I just respond on that? Congratulations on that appointment. That was clearly a much sought after appointment. So congratulations. I think from my perspective, if we only focus on what the Cabinet does, the real danger is we miss all of the health, the actual architecture that we want to keep away from scrutinising, but we miss all of those bits and pieces. And, you know, I think we should look at our role as health and well-being of our residents, and a lot of that is underpinned by GP access, about referral rates, about all of those other things. So I think we'll pick up the corporate priorities as part of that September meeting that we're looking to diarise, and it'll be a single item agenda because we want to go through that in detail and understand how that interlinks to create that integrated care partnership that Simon and Marcus were talking about, because we have a role as a county council to play in that integration of care, and I'm sure Richard would say as much as well. Is there anyone online who wants to add anything to what has just been said?
Could I just perhaps clarify? I didn't perhaps explain what I should have done, or should have said. We should not ignore anything that's on the cabinet papers that regarding health. They are a must. They're a given for us, I suggest.
Absolutely noted. Okay, can I make a couple of suggestions so that we can move to the next agenda item? There's a proposal in front of you. I think that Councillor Charlotte Atkins made a very logical and sensible suggestion in terms of dentistry. And I suggest that we try and slot that into the agenda possibly for August. Because A, July looks big and busy. And B, we're going to ask people to actually bring some knowledge and insight and reports that actually we're going to need to go and ask for. I'm not suggesting that some of the detail isn't there, but they're going to need to pull it together. So I'm going to suggest that we actually add that to the August meeting. And then we take away the other parts of the discussion and send those round in terms of where the themes will get picked up. And equally, the bits that we struggled to integrate, we can then at the next meeting decide whether it is more critical than another element or whether we slot it in later of the year. So there are two proposals on the table. One is that we put in dentistry for August, and two is that we'll revert with the themes that we've just discussed around this room. Are we in agreement?
Yes, Chair.
Is anyone not in agreement? That's good. Okay, thank you. Useful debate, and thank you for your input to that. We won't lose any of those themes, and if we don't get them into the programme early enough, just keep coming back, and eventually, through the weight of public demand, they will get into the themes. So, moving on to the next item, which is item number 6. COVID-19 vaccine programme update. Before I bring you in, Lynn and Paddy, first of all, apologies. Next time I think we'll give you a time slot so it helps with your day planning. So apologies for that. We'll try and work that better for you next time. And I think in terms of your other colleagues, we probably can offer them the opportunity if they would like to go and get on with other things they might want to do. Marcus, Simon, Richard, Tracy. So thank you for your input. Thank you for the help to creating the work programme. And if you want to stay with us, that's great. If not, thank you. Lynn.
Okay, thank you, Chair, and hello everybody. And I can just see Paddy's joined us. So we've got a brief presentation for you today, which Paddy and I will do together. So I'll just get started straight away. If we go to the next slide, please. So just in terms of the numbers, we've got some big numbers in there. So 55 million vaccine delivered in England, 1.2 million in Staffordshire and Stoke-on-Trent, of which 700,000 are first doses, and actually as of today, when I last looked, it was 530,000 second doses, and what we're seeing is a really big focus on the second doses and bringing those forward, and I'll come on to a bit about that. We've got some really high uptake in Staffordshire and Stoke-on-Trent, so of cohorts 1 to 9, so everybody over the age of 50, healthcare workers, etc., we've got a 92% uptake rate in the whole of that cohort, and the follow-up rates in that is like 86% as well. So people are coming forward, which we're really grateful for that, to get that very important second dose. We have vaccinated all 330 of our eligible care homes and have got very high uptake rates amongst residents and care home workers and staff. And we continue to visit the housebound patients. So people who become housebound, often it can be a temporary measure, and we're still going into people's homes to do their vaccinations for them. One of the statistics I'm really proud of actually is our uptake rates for people with learning disabilities. We talked around harder to reach groups and the inequality that we have in not just in Staffordshire, but I think it's been exposed by the programme. And historically, we haven't done very well in terms of some of our support services for people with learning disabilities. So we've really focused on how we can go down to a granular level to personalise the vaccine programme for this quite difficult and challenging group of people sometimes. And you can see we're at 87.7% vaccination rate compared to about 79% nationally. And that's what we'll always continue to do. I often talk about not leaving anyone behind, and certainly that's the case for this group of patients. We've been chosen as one of 21 sites nationally to deliver the Moderna vaccine. So Tunstall, run by MPFT, is currently delivering Moderna. And again, that shows the level of assurance that the region have in terms of us being able to manage multiple vaccines. So currently Tunstall delivers AstraZeneca, Pfizer and Moderna on one site, and it's very, very tightly run. As our chair said, we still remain to be one of the highest performing in Staffordshire, both regionally and nationally. And that's very much down to our approach, I think, and all of the partnership work and the innovation that we're doing. Come on to a bit about that later. And the vaccine supply has been sporadic, but whenever we get additional vaccine, we take it and we don't waste it. So if we can move to the next slide, please. So it's very clear that there's no end point to the vaccination programme at the moment. So what we see it as in terms of 4 phases. So phase 1 is when we started in December, so the cohorts 1 to 9, and we continually go back to review that and ensuring that everyone's had that opportunity. Phase 2, which is where we are now. So this is everybody under 40, and I think it's fair to say we have to have a very different approach in terms of encouraging uptake rates amongst these age groups. They're not necessarily as compliant in terms of medicines uptake as older generations, and so we're really having to think differently. This is about access, this is about the right communications, and what we're doing now is ensuring that it's convenient. We're taking the vaccine to the people rather than expecting people to come to the vaccine at times of the day that's just not convenient to them at short notice. So we're taking a very different approach, and I'll talk a little bit about the targeted vaccination service that we've got in place and how we're doing that with our partners. Phase 3, we're thinking ahead to autumn. Now, we don't know what's going to happen from the autumn onwards, but we think, but we do know what we think, if that makes sense. So we're planning for a number of scenarios. So while we're waiting for national guidance around the need for a booster, for example, we're modelling what that might look like. So flu is going to be very important this year. So we're going to be managing 2 vaccination programmes potentially at the same time with extended age ranges. And also, as you might have heard in the news over the weekend, the possibility that we'll be vaccinating secondary school age children between 12 and 17, all in that autumn period. So what we've done is we've refreshed our programme structure. We've added some permanency to the programme team. So previously we've run the whole programme through people's existing roles. So and that's just not possible going forward. So we've reviewed that programme structure. We've got some national funding to support that. And we're doing the modelling now to understand what capacity we might need dependent on what programmes, what additional vaccine requirements come in the autumn. I think it was picked up previously. I think Simon picked up on the need for this to become business as usual, and certainly we'll need some kind of vaccination strategy that will take us between the next 1, 2, 3, 4, 5 years. I think the importance of vaccinating our population can't be underestimated. So we need to really incorporate our other vaccine programmes around flu, children's services, children in this programme. We'll be working very closely with our public health colleagues to develop that strategy. So we can go to the next slide, please. I'm sure most of you have heard around the new variants that are coming into play that are potentially affecting the vaccine. What we've done locally is, what nationally we've been asked to do is move forward our second doses from 12 weeks to 8 weeks. The reason being is, while the vaccine is still extremely effective, for the new variants, we're certainly seeing a lower rate of effectiveness after the first dose. It's only when people are double dosed that we see this, the 80-85% effectiveness. So it's really important that we've been able to vaccinate that vulnerable group as soon as possible. And for the next remaining 2 or 3 weeks, we will have vaccinated an additional 145,000 people to bring that vaccination second dose date forward. It may be that I invite Dr. Hannigan just to touch on this. We've been working very closely with public health again around areas where we've seen outbreaks. And just last week, we were able to put on additional services in Leek. Paddy, would you like to come in on this?
As Lynn said, we've got a national sort of surge response in response to the new variant, and our local surge response. We had a discussion 2 weeks ago with all system partners about our approach to this, and it was very much around trying to improve our uptake rates in the areas which were currently at lowest uptake. All areas have fairly good uptake, as Lynn said, but there's a couple of areas, particularly in Stoke-on-Trent, but also in Tamworth, that we would want to try and in Burton, that we'd want to specifically target. So we'd sort of developed that idea 2 weeks ago. Obviously, particularly through last week with the leak response, we've sort of brought that into our thinking. And so as of today, we're extending the vaccination in leak to include everybody over the age of 18, so down into cohort 12. We're hearing that that's going to be a national view probably this week, but we've sort of we've responded early, and we have the capacity through our stand-up team with MPFT that we can offer vaccination to the whole of cohort 12 for the Leek population, anybody who attends the 3 affected schools in Leek, and that should be available through this week. And we have sufficient capacity and sufficient vaccine through the Tunstall Moderna vaccine to offer that without stopping or reducing any of our other elements of our programme.
Thanks. So, next slide, please. So I think this pretty much repeats what we've already said around the need to vaccinate more people more quickly and bring forward those second doses. It's about vulnerability and risk. We have got enough second dose vaccine in the country. So when first doses were given, the government effectively banked their second dose. So everybody's second dose has their name on it. So we're not concerned around the availability of the vaccine. And we've given 530,000 so far. So we're well on the way to deliver the national ask. So go to the next slide, please. Just in terms of access, we've got 23 local vaccination centres, which are managed by our GPs through the primary care networks. We have 11 pharmacy sites, and we also have 3 large-scale vaccination centres, so 1 in Tunstall and Stoke, 1 in Stafford, and 1 in Orwell. The map shows that geographically it appears to have some gaps, but now as the vaccines have become more portable and more easily manageable through the cold chain, we're able to provide perhaps some more local services through GP practices as well. So we've got really good access. No one should be travelling more than 7 to 10 miles to receive their vaccine in Staffordshire and Stoke-on-Trent. And I think the national target is 15 miles. So we've made sure that people have got that local access. We do have some PCN sites, the primary care network sites, that chose to opt out of cohorts 10 to 12, so the younger age range. But that was always part of the plan. We always knew that the reach of general practice was best placed to target the older generations and those in more difficult to reach groups. And actually people wanted more convenience of pre-booked appointments, for example, through the vaccine centres and pharmacies. So we've still got a good percent coverage across the patch. So if we could just move to the next slide, please. So this is a great example of how we're working very differently with our partners. So as I said previously, what we're doing to target some of the inequalities, some of the new cohorts is to bring the vaccine to them rather than expecting to access the vaccine in the normal way, if you like. So we work very closely with the Staffordshire Fire and Rescue. So this is Fire Officer Chris Williams, who's been leading this piece of work with us. And we use their vehicles and drivers to bring our vaccination teams to different sites around Staffordshire. It's really made a huge difference into reaching out to more ethnically diverse communities and people that historically perhaps wouldn't have reached out to healthcare. So we've been working with faith leaders around the mosques. We've taken the vaccine to fruit farms, and we've got 19 in Staffordshire. So huge cohort of people there that perhaps wouldn't have been able to access the vaccine in a normal way, many of which are not registered with the GP. We've been to African Caribbean Society, and we're currently working with some of the large-scale employers like JCB, Amazon, etc., around how we could put pop-up clinics on and those employer sites as well. I was just on the phone finalising the arrangements with some of our universities this week, so we want to capture that cohort before they disperse back to the homes. So this is really helping us to work quite differently. And certainly the fire service has got a different response from people in terms of that's what we could have achieved with health. So it's using everybody's skills, everybody's relationships to make sure we vaccinate as many people as we can. And one of the things that we've been very focused on is the inequalities, particularly amongst ethnically diverse communities. So we 6 weeks ago, when we started to look into the variation that we had, there's some very clear inequality in certain ethnic groups. So we were only at 43% uptake in the Pakistani and Bangladeshi communities because of the work that we've been doing with faith leaders, because we've been going into that very granular detail, personalising the service, if you like. We're now at 78% for the Bangladeshi community, and we're starting to push up all of the other groups as well. We've still got a bit more to do around Black and African Caribbean communities. Certainly there's a level of distrust that may be cultural there, but we'll continue to do that to make sure nobody gets left behind. So we go to the next slide, please. I'm going to hand over to Paddy now.
Thanks, Lynn. Next slide really is about vaccine hesitancy, and we say that quite distinctively because the uptake rates in the first 9 cohorts for the county are just over 93%, which is unprecedented. I mean, our national flu campaign, traditionally we would get in the low 70% uptake. Last season, because of the COVID effect, we saw that at around 80%. So a 93% uptake is unprecedented. What we're seeing as the cohorts fill is that there is a degree of hesitancy amongst some of the population. I think there's a lot of anecdote and to be honest, myth around the hesitancy. What we're seeing is that if you can tailor the information and tailor the response, and particularly listen to people about what their concerns are and attempt to answer those, is we slowly and surely see the cohorts fill. So we see, as with any adoption curve, we see people who will beat on our doors to get their vaccine. We will see people who will come along fairly quickly behind. Then there's a bit of a tail, and it's the tail where we need to do this work. And so we've seen a number of different issues around fertility and pregnancy, and a number of sort of drivers of concern. But the reality is that the cohorts slowly fill, and and it may take some weeks for that to happen. And we look at every cohort's uptake figures every week, and I still see people in cohorts 1 to 4 having their first dose every week. So this tail does eventually fill up, and as I say, the over 50, we're now at 93%. I think the same thing will happen with all the other cohorts. I think the uptake rates across cohorts 10 through 12, although we talk about young people being different, I think we will see exactly the same phenomenon, and we will see a slow and steady fill. And I think we'll see uptake rates really very high across all cohorts. Another example, I guess, is the care home staff. Lots of noise in the press about, do we need to compel care home staff to have their vaccination? No, we don't. The reality is care home staff vaccination rates are comparable to the rest of the population. It's taken quite a lot of work, and certainly the teams within the Staffs County Council and Stoke-on-Trent City Council who work with the care homes have done a lot of work, a lot of webinars, a lot of myth busting, and a lot of conversations with individual care homes and individual patients, but it works, and so as an approach, it's effective. So it's about hesitancy. It's not really about anti-vaxxers. It's not really about people who are not going to get vaccinated. It's around giving people the tailored information. Can we go to the next slide? AstraZeneca, people will know the story about blood clots. The risk of AstraZeneca blood clot is a fraction of the risk of a blood clot from taking the combined oral contraceptive, which we've been doing for 30 years. Well, not personally, but we've been prescribing for 30 years. But we need to be proportionate about the risk. The risk is it has been quoted as around 4 per million doses. Unfortunately, we have some local cases where we've had otherwise fit and healthy people who have had an AstraZeneca blood clot, and that sort of noise does travel. The national response to this is as the COVID vaccination rates have fallen, is the balance of risk and benefit in the younger population has changed. And so we have seen first with cohort 12 and now with cohort 11. So anybody under 40, we will offer them either the Pfizer or Moderna vaccine. I don't think the impact of this in terms of uptake rates or work through the sites has been particularly onerous. When I've been the medical director at the county showground, I do get questions, but they're fairly easily answered, and I don't think this is having a big effect on our uptake rates. Next slide.
So we've taken a bit of a pause recently to look at how we're able to achieve what we've achieved, and certainly these are some of the that have meant we've been able to deliver such high levels of performance. I'll leave you to look at those in your own time, but if I could pick out 3, it really would be top of the list would be the true system and partnership working. I never want to go back to not working like this. It's been a hugely enjoyable experience working with partners in local authority, in the fire and the police, and it's certainly meant that we've been able to do things that we wouldn't be able to do on our own as health. So I should give you some examples. We worked very closely with the City Council, who led on the vaccination centres, the large-scale sites establishment. But they didn't do that just for Stoke. They led on that piece of work across Staffordshire, working with colleagues in the local authority in Staffordshire as well. And I think that distributed leadership with people working across the boundaries, working as part of a programme approach with very clear objective and a shared purpose has been fantastic. If you saw the range of organisations we work with, it really is extensive, and voluntary sector have been absolutely crucial. Various aspects of the local authority teams, but people have really taken responsibility to lead. The third area for me, which has really been an eye-opener actually, is the work we've done around inequalities. You've heard me say before that around our mantra, not leaving anyone behind. It's the first time I've worked on a programme that's covered 100% of our population in Staffordshire. And when you use the data to drive the programme, you can really see where the inequalities exist. And actually that wasn't acceptable to us as a programme. And Neil Carr was very clear as the SRO that he wanted to see a very focused programmed approach to inequality and access. It's very fair to say that one size doesn't fit all. It takes effort, it takes focus. You have to go the extra mile. You can't just expect people who are perhaps not used to accessing healthcare or have not been engaged with healthcare to suddenly step up and do what we want them to do. It's been completely underpinned by the comms support, both in health and care. The comms strategy has been absolutely excellent, and again has been tailored to meet the needs of the different groups to ensure that they get the right information from the right people and the right language, for example. So yeah, it's a really good example of the system, both health and care pulling together and public sector pulling together to do a really good job. So just in terms of the final slide, please. Yep, so we're certainly seeing less outbreaks in care homes now. I think I was speaking to Dr. Paul Edmondson-Jones last week, and he said there was only 3 individual cases in Stoke-on-Trent. The same for our Staffordshire homes, very low levels of outbreaks, and when they do, very low levels of illness. It's still the message has to be about not being complacent. It does take time for the vaccine to take effect following that first dose, and we need everybody to come back and get their second doses. So help and support with the messaging around that would be really gratefully received. And obviously, yeah, as the chair started the session, hand, face, space and fresh air. You really need to be that mantra while we get everybody vaccinated, particularly as we've got new variants that we're tackling as well. So I think that's the end there. So I'll pause. Thank you.
Thank you, Lynn. Thank you, Paddy. Endorse everything you say. I'm just going to take Chair's licence just for a minute. And cover 3 things, if I can, please. Can someone just turn their extra microphone off, because it's... Thank you. So I'm just going to say 3 things. I think your equalities point is exactly right. And I think actually it's those people with some of the inequalities who are probably most at risk as well. And so as a result, it was a double disadvantage, so to speak. So thank you for the work you've been doing on that. And I know it's been a consistent mantra. One of the slides asked when you were looking at the vaccine hesitancy, what can you do? I noticed that you've got a vaccine webinar scheduled for Wednesday the 16th at 5:30. Do you want to just sort of talk a bit about that in terms of what you're trying to achieve with that and how you'd like that promoted through other partners, members, councils, as far and wide to the relevant audience as possible? And then the third question sort of relates to leak. It's 2 parts. Is there a postcode check on who is eligible within leak? And second of all, will people be contacted or is it just a rock up and see? Thank you.
Lynn, do you want me to...
Yeah, do you want to pick up the webinar?
Just for the... No. I'll try again, it's just a bit echoey. Okay, on the 16th of June, what we have said is that, because many members in other overview scrutiny, district and boroughs committees were wanting a vaccine briefing, and because obviously it is a key area of delivery for us, we thought we would put on a webinar to ensure we can have the widest access with yourselves, your fellow county councillors, district and borough councillors, and extending that down to the parish councils, because that helps us with our messaging as well. You you really can help us, and you really have helped us, for which we're really grateful. Of getting the messages out. You talk to your constituents on a regular basis, and you can help support us with the positive messaging around vaccinations. So we're working with the communications team in the local authority to ensure we get out the proper Eventbrite message and making sure that the link is there for the 16th, and you will receive a presentation, probably a more detailed presentation at that meeting, and it'll be more up to date by then, and I'm sure there'll be a lot more vaccines that have been delivered by then, and it'll give you all an opportunity to ask questions there. So be happy for you to advertise that widely, and we will ensure that we can get people on there.
Thanks, Tracy. Paddy, do you want the leak coverage?
Yeah, so the national booking system that we use for booking some of our sites isn't open under the age of 30. So whilst our response to leak is to vaccinate into cohort 12, we need to run that slightly differently. So it's been booked on Eventbrite, and that's being released on a daily basis with, I think it's up to 600 slots per day. And that will run probably for about the next 7 to 10 days, depending on uptake. We are, and the comms team are publicising that. And we are publicising it as being over 18. Although that's caused a little bit of a discussion with NHSE around doing that, because it's slightly outside the national programme. So it has sort of slightly limited our comms. We are doing we're asking people to bring a proof of residency or a proof of association with the school when they come in. We have had some experience of using Eventbrite to run other clinics, and we do find that the invitation gets spread fairly widely, fairly quickly. So we are doing a little bit of a check. I think, to be honest, this is going to disappear during the course of this week, because the noise is that the national booking system will start to open up to cohort 12 probably fairly quickly, if not in the next few days, at which point anybody in cohort 12 anywhere in the county should be able to book through the national booking system or through our LVS site. So I think our immediate response is quite localized, but it will probably change during the course of this week.
Thank you. Can I just bring in Charlotte?
Yes, obviously it's on the leak situation as well. Obviously there's been quite a lot of surge testing in leak, and what I'm getting from some residents is that where they have the sort of whole family of being tested, that they're getting responses back from some of the tests and other tests they're still waiting for. One, how long would you expect them to have to wait for a test result? And two, when a family gets tested together, why aren't they getting the results back together?
I suppose, Councillor Atkins, that's sort of a bit beyond our remit in terms of the vaccination programme. I don't know if Richard's still on to perhaps give an update on the testing element.
No, I think I'll let him go, in fairness. We'll take this up separately outside, because you are right, it's a test and trace and public health there, so thank you. We'll come back to you separately on that, Charlotte. Janice.
Thank you. Just a quick question, just for clarity in my own mind there. Knowing that the vaccine's just been certified for the 12 to 15-year-olds, is it likely that it will follow the HPV route and will be delivered in school? I did see on the phase 3, it did say that you were still waiting for further guidance, but would you envisage that it would do that?
Yeah, I mean, the Joint Committee for Vaccination and Immunisations hasn't sort of given the go-ahead yet, although the Medicines Regulation Authority has, so we're waiting on that. Our current planning involves rolling it out through schools through September, alongside potentially a flu programme. So it's part of that scenario planning where we're trying to look at the numbers, look at what model we need to deliver that. But certainly we started those early conversations with MPFT that provides the school service. It may be, though, that we need to do something different. So we're open-minded to what the model might look like, and it's about the numbers and the capacity to deliver it. But we're certainly prepared.
Do you want to come back, Phil? Oh, sorry, I thought you indicated that you wanted. So I'm looking around the room for any further questions. And on that basis, I think we probably as a committee, given that it's the first time we've met as a full committee, do we want to express our thanks for the work that is being done by Paddy, Lynn, Neil and the team? I think that's a resounding yes, so please can you take that back to all of your staff, volunteers and anyone involved, and partners obviously. And thank you for coming this morning, and we look forward to seeing you in a month or two's time. Thank you.
Thank you, Chair.
Thank you.
Thank you. If you want to stay, please feel free. If you want to go, please feel free. That brings us on to item number 7, which is the district and borough scrutiny activity. We have noted in front of us what is there. What are the additional elements that people want to mention? Okay, no one's volunteering that they've done a meeting and it's outside of the papers and they want to raise it. So there's no point in prolonging the pain and agony. So on that basis, let's move on to item 8, which is the exclusion of the public. There is nothing no reason to exclude the public. So that brings me on to the date and time for the next meeting, which is Monday the 5th of July. Thank you for this morning's attendance, and I look forward to seeing you then. This meeting is now officially closed. Thank you.